Srinivas sir is the first.
So famous.
So, having greeted all of you, I will mute myself. I am a learner now. It's always a pleasure listening to you.
Thank you, sir. Thank you.
Not only we learn something, we also see some old film actors, actress, and some correlation with some so many other things. For your histopathological picture with saris.
Sreet, and the sound is okay. Am I audible, Sreet?
Yes, sir. Yes, sir. Very much audible, sir.
Thank you.
Sound okay.
How is the COVID there? COVID in Pondicherry, sir?
Come down to 8.
Pardon, sir?
It has come down to 8. What about Kerala? It was increasing alarmingly. Now it's okay.
We are always in the front, and Calicut is the best. Is always first. Calicut district.
Yeah.
Maximum number of cases in Calicut.
Yeah. Previously, it was supposed to be Kerala was supposed to have controlled so well.
Ulta ho gaya hai.
Appreciating. Suddenly, it has gone up.
Yes.
Of your youth, what are you taking?
Pardon, sir?
How you remain so youthful? So what is the secret? Except occasional graying of this thing. A good wife, good family. Besides that, any other natural herbal medicine.
Always being with children, pediatricians are like that, sir.
But I am also a pediatrician.
You're also, in the heart, you're also very young, son. You're always very young at heart.
Two articles I'll forward. Not that you don't know anything about that.
No, sir. Please do forward, sir. More articles.
Two recent articles with excellent picture. This thing. One is from China. Chinese presentation on neonatal inherited cholestatic disorders.
Okay.
2018, and one is 2019. So it will be too basic. But if it is, if I'm not carrying coal to Newcastle,
no, not at all. Not at all, sir. Not at all.
I can send it to you, but you should
please
not.
Do, sir. Please do. Please do.
You should not get offended.
No, please do, sir.
No, it has become a disease. Whenever I read some interesting articles, so I send it to some immunodeficiency disease. I send to some immunodeficiency pundits in Bombay, Bangalore, and this thing. So I feel sometimes delicate. These people will think, where is the time for them to look at these articles and whether what they do not know already about these things.
No, sir, no, it's not like that. So I also need the articles on immunodeficiency. Please send me also immunodeficiency articles on immunodeficiency.
Yeah, I can send you.
Please, please. Sir.
Yeah.
Madam, now it's time. Should we start, madam?
ശ്രീത്ത് വേണം കുറച്ചു നേരം വെയിറ്റ് ചെയ്യണം, കുറച്ച് ആൾക്കാർ വരണ്ടേ. കാരണം ഇൻട്രഡക്ഷൻ കേട്ടില്ലെങ്കിൽ അവർക്ക് മനസ്സിലാവില്ല. പ്ലെന്റി ഓഫ് ടൈം. നമ്മുടെ ആൾക്കാർ ഞാൻ എന്റെ പീസിന് വിളിച്ചപ്പോൾ അവർ പറയുന്നു, സാർ 4:30 അല്ലേ ഉള്ളൂ എന്ന് വെച്ചാൽ ഞങ്ങൾ കാത്തിരിക്കുന്നു പറഞ്ഞു. They won't come in time. Anant Keshan, good evening. Anant.
Good evening, sir.
Good evening. Good evening. ഓ ശ്രീനി ആണല്ലേ. ശ്രീനി
ശ്രീനിവാസനെ സാറേ കന്നഡയില്ല ഇപ്പോ.
കന്നഡയിലായിട്ട് പെട്ടെന്ന് മനസ്സിലായില്ല. ആനന്ദ്.
Hello, sir. Good evening, Anand Keshavan.
Yeah, good evening, sir.
Always nice to see your happy face. Hello, madam.
Good evening. Good evening.
Good evening. So I am a learner now. I am one of your students. Yeah. Afternoon, when he rang me up, Riyaz, I was listening to Dr. Sankar Narayan taking classes to PGs who are appearing in exam, DNB exam. So some 6 or 7 conditions he was discussing.
Madam, നടന്നുകൊണ്ടിരിക്കുകയാണ്. ഞാൻ എപ്പോഴും നടത്താനുള്ളോ?
Always pleasure watching all of you.
Yeah. Srinivas sir, Sumi's programs decreased now, right? Number of programs decreased now.
Hello?
Yeah, considerably. Considerably. I was invited as a panelist for Bombay for Pedicon, but I developed some parotid swelling for the last 3 days. After eating, it becomes big. Then within 1.5 hours subsides, so I have to get it investigated. So my dilatation or obstruction of parotid gland. Ask Basavaraj to nominate Dr. Maitri or some other person for.
It is we can do both. Basically, virtual we can do it.
Yeah.
Both way we can do it because I am also panel discussion is there. I am going. My panel members are not coming.
Yeah.
Parvati madam, good evening.
Good evening, Riyaz. Good evening. Good evening.
സുഖായിരിക്കുന്നു madam.
സുഖായിരിക്കണോ? How are you?
I'm fine.
നജീബയുടെ ടോക്ക് കേട്ടോ കഴിഞ്ഞ ദിവസം.
Leprosy.
It was good.
Madam, I was asking Riyaz, what is the secret of his youthfulness?
That's being with children, pediatricians.
Pediatricians always keep young. They feel young.
Response he gave.
Be positive. Yes.
I think coconut oil of Trivandrum keep you all young. It's a very maligned oil.
Yeah.
People are scared.
Yes. We make our own coconut oil, sir. We make copra and make coconut oil.
Welcome, Dr. Prashant, pediatric gastroenterologist from Trivandrum.
Prashant.
See, we can start at 4:35.
Okay.
Don't waste time.
Okay, madam, shall we start, madam? 4:30, already 4:35. Ready, madam?
Am I audible?
Yes, madam. Yes, madam.
Okay. Good evening, everybody. Welcome to all the PGs, IAP members, senior members, Srinivasan sir, Parvati madam, Saroja madam, Anand Keshwan sir, and all senior members, Pediatric Gastro, Dr. Prashant Soban. So, welcome all to the Thrissur IAP PG Club activity. The case that is being presented today is approach to a child with cholestatic liver disease, being presented by PG Renu Davis from Amla Medical College, and the discussion will be held by Dr. Riyaz, HOD Pediatrics at KMCT Medical College. This is our Thrissur IAP's third PG teaching activity. First one was presented by Dr. Salu from Government Medical College, Thrissur, to none other than the teacher of teachers, Dr. Srinivasan, who's there amidst us today. The second by Dr. Jewel Maria George from Jubilee Mission, presented to the renowned teacher, Dr. Sushma Bai Madam, approach to a child with developmental delay and seizure. Both were very well presented and we had a very lively question and answer session. So all the best to you, Renu. And before starting the session, a short introduction of our speaker, Dr. Riyaz. Dr. Riyaz is the professor and head of pediatric gastroenterology at KMCT Medical College, Calicut. He was the former professor and head of the pediatric department at Calicut Medical College, and he has a UG teaching experience of over 40 years, PG teaching experience of 35 years, and has been the UG and PG examiner in various universities. He is a member of the PG board at Calicut University and has published over 40 articles. Among the books he has published, the well-known ones are the Textbook of Pediatric Gastroenterology and Hepatology, Review of Pediatrics, Frequently Asked Questions in Pediatrics, and he has contributed several chapters to various textbooks. Over to Dr. Riyaz for the discussion. Dr. Riyaz?
Okay. Good evening, everybody. I'm really happy to see the teacher of teachers, Srinivasan sir, my respected teacher, Parvati madam, my dear old student, Dr. Anand Keshavan, Purushothaman, Dr. Srinivas, Dr. Shriji Jijit or Shriji Joseph. And I would like to thank first of all Dr. Srijit and Dr. Deti for giving the privilege to present this program. So the outline of the program is something like this. We shall discuss the cholestatic liver diseases from an examination point of view, that is from an MD-DNP examination point of view. So I will be brushing aside other systems like social history, other systems, social history development, etc. We won't be giving much time to discuss all these things because I'm sure you have got better teachers for that. Dr. Renu, I'm sorry about the spelling. Dr. Renu, I'm told is that she is one of the best PGs of Amla Medical College by none other than Dr. Shriji Jijit. So let's see how good she really is today.
Thank you, ma'am. Thank you, sir.
Okay. So what actually she has sent her presentation to me, and what Dr. Renu has prepared will be in black letters. Okay. And my question in between, I will be asking several questions. So my questions or my comments will be in red letters. So Renu has to read only what she has sent me. Okay. The questions I will be asking will be in red letters. So you can either unmute yourself and an answer or write in the chat box. And the chat box will be examined by Dr. Srijit. Hello, Prashant. Prashant, good evening, Prashant.
Good evening, sir.
Good evening. Now, after the case presentation, once it is over, we shall have a revision class also. Okay. In the revision class, I will be projecting questions and photographs, again from an examination point of view. So this will be a review of what we already studied. And there may be some additional questions also. And Dr. Sridhar, please remind me when the time is over, about to be over. Okay, you cannot, at any time I can stop because there's no time limit for me as far as I'm concerned. So relax and enjoy the class. Are you ready, Renu? You are ready?
Yes, I am ready, sir. I'm ready.
Okay, here we go. So start.
Good evening, everyone, respected teachers, colleagues. I'm presenting a case of 75-day-old female child, second child of a non-consanguineous parent, hailing from Kundankulam.
So you can see that I have highlighted three aspects. Okay, one is the female child, non-consanguineous parents, and the place she's from Kundangalam. So the first question to you: what is the significant importance of gender in cholestatic liver disease? What is the significance of gender in cholestatic liver disease? Is it really significant?
Yes, sir. In certain conditions, there is more of female preponderance.
Which are these conditions?
Sir,
That's okay. So these conditions are actually easy to remember because the surgical conditions, biliary atresia and choledochrosis, these are the surgical conditions. You can remember the tip is that both surgical conditions are more common in females. Then what the relevance of consanguinity? You said that this child is born to non-consanguineous parents.
Yes, sir.
So what is the significance of relevance of consanguinity in a cholestatic liver disease? Suppose your child is born to consanguineous parents. What are the possibilities?
Sir, autosomal recessive conditions.
That's right. So there are several autosomal recessive conditions which can present with cholestasis, cholestatic liver disease, like galactosemia. It's the cousin of galactosemia is hereditary fructose intolerance. We have type 1 tyrosinemia. I'm sure you know about PFIC, progressive familial intrahepatic cholestasis, gestation element. All these are autosomal recessive, and there are several others also. So that's the relevance of consanguinity.
Yes, sir.
You said this child is from Kundangalam.
Yes, sir.
Okay. Name the countries the highest incidence of biliary atresia in the world.
Sir, Taiwan and Japan has got the highest incidence. Taiwan
that's very
being
good.
on
That's
the top.
Very good. Actually, I was about to give a tip. This was the first tip. Who is this?
Sir, the stool chart.
Who is this?
Zeng Cheng. Zeng
she's trying to guess Taiwan. She's trying to link Taiwan and this condition. But look at the face. This is a very famous pediatrician.
Tomisaku.
Yeah, his first name is Tamisaku.
Kawasaki disease, sir.
Kawasaki. So what has Kawasaki got to do with? No, Kawasaki descendant, but Kawasaki is from Japan.
Japan.
Okay. So Japan, I gave the clue as Kawasaki. And this is, what is this?
So this is the stool chart. 1 to 7 colors for
that's right. Stool. So this was from Taiwan. So that is the relevance of the country. The highest countries with the biliary atresia in the world are actually Taiwan, followed by Japan.
Japan, sir.
Okay. Presenting complaints. Yes, start.
Presenting complaints. So mother gives history of noticing. Mother gives history of noticing occasional pale stools over the last 1 month, and bluish lesions over the face, trunk, and buttock since 2 weeks, and yellowish discoloration of sclera and dark colored urine for 1 week.
So, Riyaz actually brought forth 4 complaints in the correct order.
Yes, sir.
So
and bleeding from the injection sites in 5 days. Yes, sir.
4 complaints. So let's try to analyze these complaints. Number 1 is occasional pale stools. What is the color of the stool of a normal newborn baby?
Sir, it is blackish, sticky.
That's meconium. That's meconium.
Yes, meconium, yes, sir.
And then the color is
golden yellow color. Golden yellow color is a normal color. Yes, sir.
Okay. So what does it mean somebody is passing pale stools?
In pale stools, sir, it could be an obstructive cause.
No, the bilirubin is not reaching the gut.
Gut, yes, sir.
Pale stool means the bilirubin is not reaching the gut. That means there is some amount of cholestasis.
Yes, sir.
Then we are saying occasional pale stools or intermittent pale stools.
Yes, sir. That means the child has passed pigmented stools as well.
Otherwise, it means that this obstruction is not a complete or anatomic obstruction.
Yes.
So this is a point against a complete or anatomic obstruction like biliary atresia. So we have to prove that, well, this may not be biliary atresia. This may not be biliary atresia.
Yes, sir.
Then he has noticed bluish lesions. These are actually easy bruisability.
Yes.
Okay.
Over
2
the
weeks.
face, buttock, pressure points. And then
what may be the reason for easy bruisability?
Sir, liver, coagulopathy due to deficiency of the fat-soluble vitamins, and then all clotting factors are produced by the liver. So, hepatic dysfunction.
It may be either due to a severe liver disease, which is causing coagulopathy, which is unlikely because subsequently we know that this child is not very sick.
Yes.
So the other reason may be that this may be due to malabsorption of vitamin K.
Fat-soluble vitamins.
Maybe because of malabsorption of vitamin K.
Yes, sir.
Then you have written a alert discoloration of the sclera. We'll come to I marked sclera.
Yes,
we'll discuss why I have marked sclera sometime later.
Yes, sir.
Again, bleeding from the injection site. This may again be due to vitamin K deficiency, or it may be due to severe liver disease, which we do not know. We'll see subsequently. Okay. Now, where is jaundice better seen?
Jaundice
Here
is
is jaundice
better seen.
better seen or better
Yes,
appreciated.
sir.
What are the
Jaundice
areas?
is better seen in areas of the body where the skin color, there is no significant melanin. Melanin masks the icterus. So in conjunctiva, on the skin over the abdomen, on over the face, these palm and soles, these are the places where jaundice can be
Okay, that's right.
appreciated.
So also tissues which are rich in elastic
Elastic
fibers. Number
fibers,
one
yes.
is tissues which are rich in elastic fibers. And she has rightly mentioned about, because bilirubin has got a high affinity for elastic fibers.
Yes,
The
sir.
second reason is, as she has mentioned, areas which are poor in melanin. So tissues should be rich in elastic fibers, and these areas should be poor in melanin also. What are these areas? Soft palate,
Yes,
conjunctiva, abdomen wall, face, and the surface of tongue, palms and soles. So these are the areas which it's easy to appreciate icterus or jaundice.
Yes, sir.
Okay, now you know that neonatal physiological jaundice is so common in our babies.
Yes, sir.
The question is, what percentage of term and preterm babies develop physiological jaundice? What percentage of term babies and preterm babies develop physiological jaundice?
Sir, preterm babies almost 60 to 70% can develop physiological jaundice, whereas in term babies 30 to 40%.
It's like that. Maybe you're almost right, but almost 60% of term babies and 80% of preterm babies. Almost 60% of term babies and almost 80% of preterm babies may develop some amount of physiological jaundice.
Okay, sir.
Now, suppose you've got a baby whose mother is complaining of jaundice on day 2. The two important questions to be asked to the mother. What are these? What are the first questions? What is the first question? What is the second question? The mother is saying that there is jaundice, or any child with jaundice. There are two important questions to be asked. What is the first question? Because you want to find out the site of pathology.
Okay, we'll ask if the baby has passed the urine and meconium, sir, and then we'll
to find out the type of jaundice. The first question: what is the color of the urine?
What is the color of the stool? Yes.
Okay. Suppose the mother says urine color is normal. What does it mean? It is unconjugated jaundice. It is unconjugated jaundice.
Yes.
Okay. What is the other name of unconjugated jaundice? It's also known as echoloric jaundice. Suppose the mother says the urine is high color, then you should be worried because that's the conjugated jaundice. Now you would like to know what is the cause of the conjugated jaundice. The second question to be asked is what is the color of the stool?
Yes.
If the stool is pale, probably that is cholestatic jaundice.
Okay, sir.
Okay, read.
So no history of drug intake other than iron, calcium, and folic acid in the antenatal period.
Okay. Now, what is the significance of history of intrahepatic cholestasis of pregnancy in a child who is presented with neonatal cholestasis? Suppose the mother gives a history of intrahepatic cholestasis of pregnancy. Recently we had a child with neonatal cholestasis whose mother had severe intrahepatic cholestasis. Sir, it's actually rare in our country. But suppose the mother does give a history, what is the condition to be ruled out?
This can be a pointer to the development of progressive familial intrahepatic cholestasis in type 3, sir, in the neonate.
So
type 3.
That may be a point in favor of type 3 progressive familial intrahepatic cholestasis. So
yes, sir.
Always try to elicit a history of intrahepatic cholestasis pregnancy. The mother does have it, and it's possible that the child's neonatal cholestasis syndrome may be due to P53.
Yes, sir.
Okay,
natal history. This was a term elective LSCS due to failure to progress. Birth weight was 2.6 kg.
Okay, what's the relevance of birth weight in neonatal cholestasis? What is the relevance of birth weight? Is it relevant, birth weight? What is the average birth weight of Indian children? What is the average birth weight of Indian children?
3 kg, sir.
It's around 3 kg. Or always try to say in grams, 3,000 grams. 3, the average birth weight of Indian baby is 3,000 grams.
Yes, sir.
So this child is actually slightly below that.
Yes, sir. Yes, sir.
So what is the relevance of birth weight?
Sir, IUGR babies, preterm.
Which neonatal hepatitis.
Large hepatitis. Large babies can be syndromic, sir. Agnès syndrome.
Okay, that's right.
And then
what about biliary atresia? What about biliary atresia? What do you think is the usual birth
biliary atresia? They're normal at birth weight, sir. They have a normal birth weight. Term babies usually, yes.
So it will be difficult to believe. It will be hard to believe that a child with biliary atresia, he looks so deceptively well. Yes, it will be hard to believe that he's got such a fatal disease.
Yes, sir.
So that's the relevance of birth weight. The neonatal cholestasis syndrome with a large birth weight, as she has rightly mentioned, is Agnès syndrome. What the other name of Agnew syndrome?
I don't know, sir. I don't know.
Oslo. You want a clue? Oslo is the capital of which country? Oslo is the capital of which
Yes,
country?
sir, someone has answered. Norwegian cholestasis. I saw.
Norwegian cholestasis. What's the other connection of Norway to pediatrics or medicine? One is Norwegian cholestasis. What is the other connection? Is
His wife is a dermatologist.
KB's Norwegian.
KB's. You heard of Norwegian KB's?
Yes, sir, yes, sir, yes.
Yeah, Norwegian KB's. So this is Norwegian cholestasis. Okay.
So baby has passed meconium within 24 hours.
What the relevance of this? Is it relevant
Sir,
or not? Suppose the baby with neonatal cholestasis syndrome is not passed meconium in 24 hours. What are the possibilities?
Sir, congenital hypothyroidism is one case
Very
where
good.
there
So
will
one
be
is
delay in the
congenital
passage of
hypothyroidism.
stools,
That's right.
which can predispose to neonatal.
So actually, I'm very happy with the answer of congenital hypothyroidism because as a pediatrician, you should never miss a diagnosis of congenital hypothyroidism. It really doesn't matter if you miss a diagnosis of Smith-Lembley autism. It's not going to matter much. But you should never miss a diagnosis of congenital hypothyroidism. Any other condition? Cholestasis and the daily passage of meconium. You want a clue?
Yes, sir.
Cystic
Gene
fibrosis.
is on the long arm of the 7th chromosome.
Yes.
Gene on the long arm of the 7th chromosome.
Cystic fibrosis, sir.
Cystic fibrosis. Okay. So if a baby has not passed meconium time, you have to rule out hypothyroidism because hypothyroidism can cause the unconjugated jaundice as well as conjugated. It can cause both.
Yes, sir. Natal
Okay,
history. Mother's blood group is B positive and baby's blood group is O positive. And baby has passed normal color stool and urine. Neonatal hyperbilirubinemia was observed on day 2 of life, for which the baby received phototherapy for 2 days, and there is no history of umbilical vein catheterization.
You can see that I have marked in green letters. What's the relevance of umbilical vein catheterization in this child? Is there any relevance of umbilical vein catheterization in our child, or what is the significance of umbilical vein catheterization? What are you trying to convey?
Sir.
What does it lead
malposition, to? Sir. Malposition.
Umbilical vein catheterization can lead on to some other complication. What is the complication?
Renal vein thrombosis, sir.
Renal vein thrombosis and gastroenterology.
Portal vein thrombosis.
Portal vein thrombosis. Okay, that's exactly portal vein thrombosis. That's one of the cause of extrahepatic portal hypertension.
Okay, sir.
So actually, this need not have been mentioned here. That's not very relevant. History of umbilical vein catheterization is not very relevant here.
Okay, sir.
Now, why is it important to know the blood group of a baby and mother? Is it really important to know the blood group of because unconjugated? Suppose there is incompatibility. Are you really worried about? Is there any relevance?
Yes, sir. Severe hemolysis due to ABO incompatibility or RH incompatibility can lead on to inspissated syndrome, sir. Yeah.
That's right. So relevance of severe RH or AB incompatibilities. There's a condition. What is the condition?
Bile inspissated syndrome. Yes, sir.
It's called inspissated bile duct syndrome.
Yes.
What is the significance of inspissated bile duct syndrome? You see that it can cause about complete obstruction of the lower end of the common bile duct.
Okay.
So the baby may present with a clinical picture which exactly resembles the name is biliary atresia.
Yes.
Okay, but this is a very well treatable, almost curable condition.
Yes.
So this condition should always be remembered. So and hence, it's very important to know the blood group of the mother and the baby, especially to find out if there is any type of RH or ABO incontinence. So what is this inspissated bile duct syndrome? Extrahepatic obstruction of the bile duct by biliary sludge. It may be mistaken for biliary atresia. And how does it can be very easily differentiated by ultrasound. So if you do an ultrasound, and how does it help to differentiate from biliary atresia? Because what happens to the biliary radicals in biliary atresia? You know what happens to the biliary radicals in intrahepatic biliary radicals in biliary atresia?
They are dilated. There will be they are dilated.
In which condition?
Intrahepatic, sir.
Intrahepatic biliary radicals will be dilated in inspissated bile duct syndrome. Okay, they will be oblate. They will not be dilated in biliary atresia. That's the reason why. Actually, the term extrahepatic biliary atresia is a misnomer. You should not call it as extrahepatic biliary atresia. Why? because the progressive cholangiopathy of not only the extrahepatic bile ducts but also the intrahepatic bile duct tubes.
Yes, sir.
So it should not be called, should not actually be called extrahepatic biliary atresia.
Okay.
So just by a simple ultrasonography, you can see that there is dilatation, intrahepatic biliary radicular dilatation. It's called IHBR, intrahepatic biliary radicular dilatation. So
Yes,
this
sir.
very simple test very easily helps to differentiate biliary atresia from inspissated bile duct syndrome.
Bile.
Okay,
Postnatal history. It was quite uneventful. Baby was kept on exclusive breastfeeds. It was well tolerated, and the baby was gaining weight.
What does it suggest here? The baby is gaining weight.
Sir, here we can, yes, sir. We can rule out conditions like galactosemia, sir, where the baby is not able to.
This baby is tolerating breastfeeds very well.
Yes,
and is
yes,
gaining weight. So this statement actually helps us to almost completely exclude galactosemia. Even the galactosemia present in later life also.
Yes,
but
sir.
if the baby is accepting and tolerating breastfeeding, that's very unlikely to be galactosemia.
Yes, sir.
Okay.
Yes, sir. And there is no poor activity or no dysmorphic features.
Okay. Now, why have marked this in green letters? No dysmorphic features. Remember that we are discussing history.
Yes, sir.
This is actually clinical finding.
Yes, sir.
So you should not combine history taking and clinical examination.
Okay, sir. Okay.
So it's better not to mention about evidence of a dysmorphic feature when you're taking history. That's a clinical examination finding.
Okay, sir.
So you can just say poor activity, you can delete the no dysmorphic features.
Okay,
sometimes the examiners may not like it.
Yes, sir.
Okay, why are you combining history with clinical examination? They may ask you.
Okay, sir.
Okay.
Now, there's no history of any abnormal movements, order, or recurrent infections, hospital admissions.
What are you trying to convey by an abnormal movement? What are you trying to say? What is the significance of no abnormal movements?
Sir, seizures.
Oh, that's it. Then you could have mentioned seizures. Okay,
okay, sir.
Abnormal movements, maybe choreography or something like that.
Okay, sir.
Okay, they could have mentioned no seizures. Seizures very important that's a very important history in neonatal cholestasis. There's so many causes for seizures. We'll come to that later. So actually, you could have written no history of seizures.
Okay, sir.
Gives directly a clue that there is no seizure activity, rather than abnormal movements, which may be choreocytosis and kernicterus and something like that. We are not discussing kernicterus.
Okay,
order, the importance of order will come to that later.
Okay, sir. Now, there is no history of fever with rash.
This is very important. What is the significance of fever with rash?
Sir, torch infections, intrauterine torch infections, CMV, syphilis,
infections. Okay.
HSV. Yes, sir.
Okay, so many.
And the baby is not, there is no history of irritability or pruritus or skin excoriations.
Again, I have written pruritus and have marked pruritus and excoriation.
Yes.
Why?
Sir, this baby is 75-day old, so we cannot properly comment
write
on.
It then? Okay, the point is that a baby can start itching, scratching only after 6 months. Maybe the itch receptors develop only after 6 months. So, and skin excoriation, you should develop when the baby is scratching only. So that's not possible.
Okay, sir.
So the itch receptors appear only after 6 months. So till then, what will happen to the baby?
Baby is very irritable, sir. Very irritable.
He will be extremely irritable. He will be extremely irritable and always cry.
Yes, sir.
You can't say that this 75-day-old baby is complaining of pruritus. Okay.
Okay, sir. Okay, sir. Now, mother has noticed occasional pale stools.
Yes. That means that maybe this child is not having a complete anatomy obstruction like biliary atresia. It may be something different.
Yes, sir.
So what is this?
Sir, this is a pale colored stool, sir.
This is the classic pale colored stool.
Pale colored stool.
What is the color, normal color of a neonate stool?
Golden yellow.
This
golden
is a
yellow
stool.
Is the, yes, sir.
So you can see this is the pale stool of cholestasis, biliary atresia.
Yes,
this
sir.
is the classic or a golden yellow stool of a normal neonate. Okay.
Okay, sir.
What is the classic description of the stool of biliary atresia? What is the classic description?
Classic description is a clay colored stool, sir. But clay, it is basically.
Yeah, that's okay. Okay, Renu, I will answer this. Okay. This question. So this is a stool. The classic description stool of biliary atresia is clay colored stool. What is the color of clay in Thrissur? What is the color of clay in Thrissur? This is the color of clay, not only in Thrissur, anywhere in India you go, this is the color of clay. Is it pale?
No.
Actually, if the baby is passing such stools, we should be very happy because it contains a lot of bilirubin. There is no obstruction at all. So why is it then called clay color stools? This may be because the clay which we are referring to is nowadays everything is Chinese. So this is the Chinese clay. You can see that the stool resembles Chinese clay. So when you say clay color stools, if the examiner asks you what is this clay, it's actually Chinese clay, not the classic clay seen in our country.
Yes, sir.
That is Chinese clay. Now, what is this, Renu?
Sir, this is steatoria.
This is the classic.
Fat.
Can you see that? The classic, oily, bulky, nauseating, highly, I'm sure, the nauseating stool of cholestasis seen in older children. Remember that such stools will never be seen in neonates, unusual neonates.
Yes, sir.
Why is it so? Why does a baby with biliary atresia, why does it not develop? You have seen so many babies with classic biliary atresia, but none of them have got such stools or oily stools. They do not even have steator. Why is it so? This is because our babies will be taking only breast milk. Breast milk contains only very little fat.
Okay.
If a baby is given plenty of fatty food, then only steator will be obvious.
Okay.
Hope that point is clear to you.
Okay.
So if a baby is given plenty, suppose he's given plenty of butter and cheese, he will develop steator, not otherwise. Okay.
Sir. Okay, sir.
So which condition should be ruled out if a baby with cholestasis does have such stools? Suppose you got a 10-month-old baby.
Lymphangiectasia.
Cholestasis also.
Cystic fibrosis. Cystic
That's
fibrosis.
right, cystic fibrosis. The classic stool of cystic fibrosis.
Yes, sir.
Oh, this is the neonatal cholestasis. Cholestator is not usually seen. We already discussed that. Okay. Okay. Next.
So there is no history of recurrent lower respiratory tract infections or hospital admissions.
What's the correlation in an older child?
Again, cystic fibrosis, sir. Cystic fibrosis.
Any other condition? Recurrent cholestasis. Gene is something 14th chromosome. Long arm of the 14th chromosome.
Someone has answered, sir. Ehlers syndrome.
Ehlers syndrome is not on the 14th chromosome. What I had in mind was alpha 9 antitrypsin.
Yes, alpha 9
okay. So cystic fibrosis, alpha 9 antitrypsin deficiency. What is the classic pulmonary pathology of alpha 9 antitrypsin deficiency? What's the classic pulmonary pathology of alpha 9 antitrypsin deficiency? Anybody? That is
emphysema, sir. Emphysema.
Which type of emphysema? That is the third year answer. Third year MBBS. So what the classic? That is pan-acinar
emphysema, sir. Yes, pan-acinar.
Any other condition wherein you get recurrent LRA hospital admission, and what is Greg syndrome?
It is the name
what
for
Greg syndrome.
Yes.
Anybody? Srijit, anybody in the chat box? Greg syndrome.
Congenital rubella syndrome.
That's right. Who has written that?
Actually, now name is written.
Okay, fine.
Okay.
Anyhow, the congenital rubella syndrome was described by an Australian ophthalmologist called Norman Gregg. Australian ophthalmologist described congenital rubella syndrome, and hence Gregg syndrome is actually congenital rubella syndrome. So suppose the child with congenital rubella syndrome has got a PDA, neonatal cholestasis, can present with recurrent LRA.
Yes,
and she has already mentioned Ehlers syndrome also, because Ehlers syndrome also they can be congenital heart disease. So when a child with cholestasis presents with recurrent LRA, these are the possibilities.
Yes, sir.
Okay, good.
Development history. The baby has got normal developmental milestones, normal for the age. The head control has not been attained, but on ventral suspension, the head is in the same plane. A baby has attained social smile. Then regarding dietetic history, baby is on exclusive breastfeeding, and baby is gaining weight. Immunization history, baby has got a BCG scar and is immunized till date. Last vaccination was 10-week vaccination.
So
no hematoma
the
injection
development
site.
was essentially normal. There's nothing much about
no delay,
development, diet history, immunization, etc.
Yes, sir.
Yeah, this is no history of seizures. So instead of abnormal movement, you could have mentioned no history of seizures. So what is the importance of seizures?
So seizures can be seen in conditions like galactosemia due to hypoglycemia. Sir,
the
and
most
then
important cause is intracranial. First of all,
hemorrhage.
always mention intracranial. So
Okay,
one of
sir.
the most dramatic complications of neonatal cholestasis is intracranial. They may develop seizure due to intracranial. This may be potentially fatal also. This is a very well treatable condition. Okay?
Yes, sir. Yes,
So
sir.
somebody asks you, what is the first thing you would do? Suppose you are practicing the periphery of Kerala or periphery of the UP or Bihar. You're seeing a baby with cholestasis on day 3. What will you do?
Sir, the moment you suspect, we should give a dose of vitamin K, 5 milligram stat.
That's right. That's the best medicine that should be given by the pediatrician on to a baby with cholestasis is always give vitamin K, because that could prevent a potentially fatal, very serious intracranial. So one is intracranial. What is the other cause? Other cause is
Sir, hypoglycemia, vitamin K deficiency.
Vitamin K deficiency.
So hypoglycemia, then hereditary fructose
condition?
intolerance, sir. Hereditary fructose intolerance.
Hereditary fructose intolerance. That's a very good answer. Will a baby with hereditary fructose intolerance develop seizures in the neonatal period? Immediate neonatal period?
No, sir.
Why not? Is it possible? And we'll come to that shortly.
Okay.
What are the other conditions? It's not only galactosis. Remember, hypopituitarism is another cause. Whenever a baby presents with neonatal cholestasis and you can't come to a diagnosis and there is intractable hypoglycemia, always think of the possibility of hypopituitarism also. Okay.
Yes, sir.
Another condition, type 1 tyrosinemia. Type 1 tyrosinemia can also cause hypoglycemia. So galactosemia, hypopituitarism, type 1 tyrosinemia. Will a neonate with hereditary fructose intolerance develop hypoglycemia?
Not
given any syrups.
Given any?
Syrup containing fructose.
What is it? What is commonly given in Kerala? We are all very fond of that. What is
honey.
Honey.
Honey. So if the mother gives the baby honey, then it's possible a baby with hereditary fructose intolerance, if it is given honey, then he may throw seizures.
Yes, sir.
Okay.
Then there is no history of melena or hematemesis.
Okay, you can see that I have marked this in green. Why? What's wrong here? What is wrong here? Something wrong here? In fact, Renu, in the first presentation itself, I had given me this. I sent you this. Anybody else other than Renu? Something wrong there?
Spelling.
Okay, Renu, what is the spelling of melena?
M-E-L-E-N-A, sir. M-E-L-A-E-N-A, sir.
So there are two spellings for one is M-E-L-E-N-A, that's the American spelling, and the second is the British spelling. The British spelling is M-E-L-A-E-N-A. Both are correct.
Yes,
but M should always be followed by E and never A.
Yes.
That's a very easy tip. This is one of the most commonly made mistakes in pediatrics. Not only pediatrics, any branch of medicine, general medicine, anywhere. Melena is almost always wrongly spelled. That's a very easy tip for that. You know how that word melena was derived from? It is derived from melanin. Melanin. What is the spelling of melanin?
M-E-L-A-N-I-N.
Naturally, it is not M-A. So now you will never forget it. Okay.
Yes,
so it is derived from melanin, and hence M should be followed by E.
Okay, sir.
Now, you had mentioned that there is no abnormal urine order. I remember you had mentioned that there is no abnormal urine order. What is the relevance of urine order in infantile cholestasis? Neonatal cholestasis. What is the relevance of urine order? Is it relevant, or can you just pass it off like that? You want a clue? You want a clue?
Yes, sir.
First clue. What is this? Anybody? Second clue? Second clue? You want the second clue?
Rancid butter.
What is this?
Cabbage.
So, rancid butter or boiled cabbage urine. Rancid butter or boiled cabbage.
Tyrosinemia.
Which tyrosinemia is a third year MBBS answer. What is the postgraduate answer? There are two types of tyrosinemia. Only one type of tyrosinemia causes liver disease. Type 1 tyrosinemia.
Type 1.
Okay. Type 1 tyrosinemia. What is it due to? This order is due to, in type 1 tyrosinemia, what is it due to? It is due to methionine metabolites, increase methionine metabolites.
Okay,
So
sir.
the rancid butter or cabbage urine and type 1 tyrosinemia may be due to increased excretion of methionine metabolites in
metabolites, sir.
type 1 tyrosinemia. Is it clear?
Yes, sir.
Now a few words about tyrosinemia. It's a rather tough topic. Which tyrosinemia causes liver disease? I just now mentioned that.
Type 1.
Type 2 or type 1?
1, sir.
Type 1. What is the enzyme deficient type 1 tyrosinemia? What is the enzyme? Anybody? Srijit, anybody in the chat box? What is
No
the enzyme
answer,
deficient?
sir.
Pardon?
No answer yet.
No. Okay. Well, that is fumarate acetoacetate hydrolase, FAAH.
Yes, sir.
Fumarate acetoacetate. I'll come to that later. I'll show you the chart later. Fumarate acetoacetate hydrolase. That's the enzyme
Hydrolase, sir.
deficient
Okay, sir.
type 1 tyrosinemia. This is characterized by very high transaminase, very peculiar disease. Very high transaminases, the baby looking very sick, very high AFP. AFP to the tune of 1.5 up to even 2 lakhs. A condition in which the AFP may be 1.5 even up to 2 lakhs. Extremely high values of AFP, think of type 1 tyrosinemia. And they have got severe coagulopathy, but serum bilirubin may be initially normal. So it may be difficult to diagnose this condition. Very high values of AFP, severe coagulopathy, but initially serum bilirubin may be normal also.
Yes, sir.
Okay. Which organs are severely affected type 1 tyrosinemia? What's the synonym of type 1 tyrosinemia? Type 1 tyrosinemia is also known as hepatorenal tyrosinemia.
Yes,
It's
sir.
also known as hepatorenal tyrosinemia.
Okay,
So
sir.
the liver is severely damaged, kidneys are damaged, peripheral causes peripheral also. It causes the porphyria-like picture. We'll come to that later. So type 1 tyrosinemia may even cause a picture which is very similar to porphyria. Porphyria-like picture may be caused. Okay.
Okay, sir.
Which biochemical change or test helps to clinch diagnosis of a type 1 tyrosinemia. Suppose you really want to make a diagnosis of a type 1 tyrosinemia, which investigation will you send?
Sir, urine succinate.
Succinyl, the urine and serum level of succinyl acetone will be increased. Succinyl acetone will be increased. It is available. It's available now in our country. Can you easily make a diagnosis? So, what is type 2 tyrosinemia? What is type 2 tyrosinemia? Type 2 is given in Nelson also. Type 2 tyrosinemia is anybody? What is the synonym of type 2 tyrosinemia? Sri, anybody in the chat box? Richter-Hanhart syndrome.
Dr. Merin has written Richter-Hanhart.
Dr. Merin, okay. Richter-Hanhart syndrome. So type 2 tyrosinemia is Richter-Hanhart syndrome. Merin is incidentally my PG from Chem City.
Oh.
So that is Richter-Hanhart syndrome. It's also known as ocular cutaneous tyrosinemia. It doesn't cause liver disease. Remember that type 2 tyrosinemia is a relatively benign disease. It doesn't cause any liver disease. It's an ocular cutaneous tyrosinemia. Name the cholestatic liver disease in the child has a strong preference for a protein-rich and fat-rich food and a severe aversion for carbohydrate food like rice. Neonatal cholestatic or cholestatic liver disease in which the child doesn't like carbohydrate-rich food like rice is a very strong preference for protein and fat-rich food. Like he's very fond of meat and fish, doesn't take rice, wheat at all. Cereals doesn't like. What is the condition?
Chubby cheeks are citrin deficiency.
So there's a lot of research going on the field of citrin deficiency. You make a short note on citrin deficiency. Okay?
Yes, sir.
For DNP and MD, citrin deficiency may be asked at a short note. It can cause neonatal cholestasis also. What the phases of citrin deficiency?
Chubby cheeks, sir. Chubby faces.
The typical phases of citrin deficiency is good. This is called chubby faces or chubby cheeks.
Yes, sir.
Doll faces is in which condition? Doll-like faces. Doll faces. Anybody? Doll faces is in which condition?
BST.
Especially type 1 and type 3. Classic faces are from von Gog's disease. Okay, von Gog's disease, type 1 and some types in type 3. Okay, Renu, continue.
Yes, family history. There's no history of jaundice or recurrent blood transfusions.
No history of jaundice or recurrent blood transfusion. What is the recurrent blood transfusion? Which virus causes hepatitis following blood transfusion?
Sir, hepatitis B.
Are you sure? In Amala Medical College, do you get hepatitis B following blood transfusion?
No, sir. Cytomegalovirus.
It is almost never seen, right? Because
we
for a
usually
very long
screen.
time,
We
we
usually
have been
screen,
giving
sir.
only screen blood.
Yes,
So
sir.
unless there is a mass casualty, in this, thousands of people are brought mass casualty, you are forced to give unscreened blood. Only then will it cause hepatitis.
Yes, sir.
But remember that there are other viruses also like hepatitis G, Sandband virus, Yon-Band virus, etc., which we are not screening.
Yes, sir.
Otherwise, hepatitis B and C caused by blood transfusion is extremely unusual in our country.
Sir.
No? Because we are giving them screening blood. Okay, continue.
So there's no history of cholelithiasis, cholecystectomy, or splenectomy, bleeding disorders, early demise, or liver diseases.
Okay, just a minute.
Yes,
I have marked splenectomy. What are you trying to convey by saying spleen? There's no history of splenectomy in the family. What's the most common indication for splenectomy in pediatrics? What is the most common indication for splenectomy in pediatrics?
Sir.
Most common indication for splenectomy.
So when there is destruction of RBCs in conditions like hereditary spherocytosis.
So why did you mention splenectomy? What are you trying to convey? What is the relevance of splenectomy here? Is it relevant, or why did you mention splenectomy in cholelithiasis?
So when there is
near to cholestasis, is unusual.
Yeah, it's not relevant, sir.
Splenectomy is usually done in hereditary spherocytosis. Okay, we'll come to that later. The socioeconomic chapters will not discuss Kuppisamy. You're all very fond of Kuppisamy criteria classification, but okay, lower middle class family. Okay. This question to somebody other than Renu, I'm sure Renu will be knowing. What's the most commonly done surgery in sickle cell anemia? Being Shiji Jacob's student, I'm sure Renu will be knowing most of my questions. So what's the most commonly done surgery in sickle cell anemia?
Dr. Kavya Menon said cholecystectomy.
Anybody other than Kavya Menon? She's my student. Anybody else? Renu, what's your comment?
Sir, it is cholecystectomy, sir. Gallstones.
The most common answer by students will be, most of the students, including postgraduates, say splenectomy. Most of the students, including postgraduates, say when this question is asked, sir, it is splenectomy. Who does splenectomy in sickle cell anemia? It is Uparwala. Uparwala. Uparwala means, who is Uparwala?
From it's by itself, sir. Auto.
Who is Uparwala? Kaun hai?
Nature. God.
That is autosplenectomy, or what is called a medical splenectomy due to repeated splenic infarcts. But remember that they are prone to develop cholelithiasis. Okay, cholelithiasis and chronic cholecystitis. So actually, the most commonly done surgery in sickle cell anemia is actually not splenectomy. It is actually
cholecystectomy, sir.
Sometimes in a patient with hereditary spherocytosis, if he is undergoing splenectomy, the surgeon may be forced to do an associated cholecystectomy also if he has got cholecystitis. Okay, sometimes along with splenectomy, he will be forced to do a cholecystectomy also in hereditary spherocytosis. Hope that is clear to you. Okay.
Yes, sir.
So the answer is cholecystectomy, not splenectomy. Now coming to the general examination.
General examination. The child looks comfortable on mother's lap and not sick looking.
I'm very happy. I'm very happy that Renu has written this. It's not sick looking, because babies with neonatal cholestasis can be immediately classified into sick looking and not sick looking babies. So she has mentioned that it's not a sick looking baby. What are the sick looking babies with neonatal cholestasis?
Sir, it could be galactosemia, tyrosinemia, then HLH, neonatal hemochromatosis,
sepsis due to sepsis. But this is not a sick looking baby. Very good.
Vitals. Pulse rate is 130 per minute, regular rhythm, normal character and volume.
Actually, pediatricians are also worried about normal character. Actually, this is given in Hutchison. But do you really think the character of the vessel wall is important in pediatrics? Because we are not seeing patients with atherosclerosis. Of course, it's given in Hutchison. But character of the vessel wall is actually not very important from a pediatrician point of view. A small baby, it may not be very significant. Anyway, what is the importance of pulse rate? Is there any relevance for a pulse rate in our patient?
Tachycardia can be
in cholestasis. What do you expect? Is it tachycardia or what do you expect in cholestasis, cholestatic jaundice?
bradycardia, sir.
You get bradycardia. It's called a relative bradycardia. Why do you get relative bradycardia? The old theory is that the bile salts may be deposited in the, may be inhibiting the essay node.
Yes.
That's one theory, the old theory which we have been teaching traditionally. Any other cause? Can you think of some other? Suppose you got a 10-year-old child with cholestatic
typhoid
jaundice.
fever. Typhoid fever.
Cholestatic jaundice. 10-year-old child with cholestasis. You know, we are not discussing typhoid at that.
Okay, sir. Okay.
Clue? You want a clue?
Yes, sir.
He has upper GI bleed. He has upper GI bleed. So he's been treated for upper GI bleed. He's given a prophylaxis for upper GI bleed. This drug is also given in tetralogy of Fallot.
Yes, sir. Propranolol.
Propranolol. So there are two. One is the theory which we already, the old theory. Second one is that an older child with the cholesterol liver disease with portal hypertension may be on propranolol therapy. Okay, so this may be responsible for the relative bradycardia.
Okay, sir.
Okay, then she has written a lot of cardiology, femoral delay. You should be knowing about radiofemoral delay, radial delay, etc., which are not going to discuss.
Now, respiratory is 38 per minute, abdominothoracic type. BP is 90 by 52 millimeters of mercury, which is between the 50th and 75th centile, a febrile child.
Okay.
Head to foot examination. There's no frontal bossing.
No frontal bossing. Okay, Rina. What exactly do you mean by no frontal bossing? What are you trying to convey? What are you trying to convey to mean that there's no frontal bossing?
Sir, features of vitamin D deficiency.
Features, so it's a very interesting answer, features of vitamin D deficiency, because this child has got something like hepatitis.
And even in
frontal bossing. What is the earliest sign of rickets? Do you really think a 75-day-old baby will develop frontal bossing? Secondary to rickets, very extremely unusual. But it's a very commonly asked question in the exam. Now, what is the earliest sign of rickets? Earliest sign of rickets is this. What is that?
Craniotape, sir. Ping pong.
Craniotape. The earliest sign of rickets is actually ping. So actually, you could have mentioned no craniotapes. Much better than say no frontal bossing, because a 75-day-old baby will not develop frontal bossing due to rickets. So from the earliest sign of rickets is actually craniotapes.
Yes, sir. Okay. Now, anterior fontanelle is 1.5 into 1.5 centimeters. Posterior fontanelle is closed. There is no case of leisure ring. There's no cataract. Scleral icterus. And then cornea appears clear.
Cornea appears clear.
Here I would like to say, sir, it is not scleral icterus, it is bulbar.
I will come to that later.
Icterus.
Actually, I will come to that later. Scleral icterus, actually I marked it. In fact, I had marked it last time also, initially when you sent it for correction. Yes, but we'll try, don't worry, we'll try to discuss that.
Yes, sir.
Cornea appears clear. What are you trying to say? Cornea appears clear.
Sir.
Which condition causes cornea clouding?
Sir, sir, posterior embryotoxin Alagilla syndrome.
That doesn't cause cornea clouding.
No.
That doesn't cause cornea clouding.
Cornea usually, sir, clouded.
Cornea clouding is classically described in
mucopolysaccharidosis
and we will come to that later.
Vitamin A deficiency. Okay. No bitoid spots, corneal or conjunctival dryness. Okay. Now head to foot examination. No obvious facial dysmorphism.
So now Renu says that there is no obvious facial dysmorphism. So the examiner may ask you, is there facial dysmorphism? It is not very obvious. So just write no facial dysmorphism.
Okay, sir.
Okay. When you say no obvious facial dysmorphism, what does it mean? It implies that there is some facial dysmorphism which is not very obvious.
Okay, sir.
So name the cholestatic syndromes with dysmorphism. What are the cholestatic syndromes with dysmorphism?
Sir, Alagilla syndrome. Alagilla syndrome, then trisomies, then Zellweger syndrome, then
the first one is Down syndrome. Most common suppose is any other treatable condition which you should never miss.
Yes, congenital hypothyroidism, sir.
It's always meant a congenital hypothyroidism.
Open wide fontanelles. Yes,
cause facies.
Yes, sir.
Then Alagilla syndrome.
Triangular facies.
Syndrome.
Sir, Triangular facies, bulbous nose,
pointed chin,
broad
forehead.
Yes.
Zellweger syndrome. What is Zellweger syndrome? What is the descriptive term for Zellweger syndrome?
Peroxisomal disorder.
Hepatocerebrorenal syndrome, and it's a peroxisomal disorder.
Okay, sir.
Hepatocerebrorenal syndrome, and this is a peroxisomal disorder. Zellweger syndrome is hepatocerebrorenal syndrome.
Sir.
And the last one is SLO, Smith-Lemli-Opitz syndrome. These are very rare condition, but someday this may be as a short note. Zellweger syndrome and Smith-Lemli-Opitz syndrome may be as short notes.
Okay, sir.
Then citrulline deficiency. I forgot our citrulline deficiency. What the facies? She has already mentioned the facies. Yes, chubby facies or chubby cheeks.
Yes, sir.
Okay.
Now, ecchymotic patches noted over the nose, then trunk 6 into 7 centimeters and buttock 7 into 7 centimeters.
There's some problem. The vitamin K deficiency may be possible.
There is no petechiae purpurae, vesicles or palmar erythema or heel scars.
Vesicles. Why do you worry? What's the importance of vesicles? Is it simple? Why did you mention the vesicles?
Sir,
it's a very important finding. I do appreciate that.
Sir. Herpes simplex.
Yeah, that's right. If a baby, a sick-looking baby has got vesicles, always look for vesicles in a sick-looking baby with neurocholestasis. This may be due to herpes.
Yes, sir.
It's one of the cause of pulmonary hepatitis also. It can cause cholestasis, pulmonary hepatitis. This requires emergency treatment with antivirals. Okay.
Exactly.
A cycle should be immediately started. Palmar erythema. Do you really think palmar erythema may be seen so early? Very unlikely.
No, sir. Chronic liver
heel
disease.
Scars. What are you trying to say? The heel scars. Heel scars. And what are you trying? Maybe
sir, had it been an elder child, sir, excoriation and all.
It's not an elder child.
No, it's a small cells. Sorry.
This is just a 75
yes,
days. Okay.
Yes, sir. Anthropometry. Weight of the child is 4.360 kg, which is a 26 gram per day gain from the birth weight. Length is 56 centimeters, which is normal for the age, and head circumference is 36.5. We expect 37 to 39 centimeters, but this is okay. Sir, chest circumference 35 centimeters, mid-arm circumference is 12 centimeters. So there are no features of PEM. Yes.
What will you look for the eyes?
Sir, discoloration of the.
First of all, you look for icterus. Always start with icterus. What other things you look for in the eyes? So this child has got icterus.
Yes, sir.
Always look for subconjunctival hemorrhage. It's one of the very important findings which may be overlooked. If you do not examine carefully, you may miss a very important finding, that is subconjunctival hemorrhage.
Yes, sir. Like in Weil's disease, no cataract.
That's right.
No cataract.
Which type of cataract seen in galactose?
Oil drop, sir. Oil drop cataract.
I think that's a very good answer. That is oil drop cataract.
Yes, sir.
The classic cataract of galactose is
oil drop cataract.
So what's the importance of oil drop cataract? It will be very easily missed in the examination. So it's just like an oil drop. So it's very easy to miss an oil drop cataract.
Yes, sir.
What is this?
So this is bitot spots. Bitot spots seen on the temporal side of the sclera, classical grayish silvery. Bilateral.
So what are the cause of bitot spots in liver disease? Why do you get bitot spots in liver disease? It is due to deficiency of vitamin A. What is the mechanism? Why do they develop bitot spots in liver disease? There are several causes. Can you mention some of the causes of bitot spots, mechanisms of bitot spots in liver disease?
So one is due to the impaired absorption of fat-soluble vitamins.
So all fat-soluble vitamins A, D, E, and K can be absorbed.
And sir, and then impaired conversion of retinol.
So cholestatic jaundice. The second one is decompensated chronic liver disease.
Yes, sir.
So what will happen? What the transport protein of vitamin A?
Retinol binding protein, sir.
RBP.
RBP
is synthesized by the liver.
By liver. Yes, sir.
The damaged liver is not able to synthesize sufficient amounts of retinol binding protein. So naturally, yes, vitamin A transport will be decreased.
And impaired conversion in decompensated liver disease.
Another mechanism. Okay. And another point is because the anorexic diet may not be taking sufficient food, vitamin A rich food, green leafy vegetable will not be taking.
Yes, sir.
So unless that's the importance of giving sufficient quantities of vitamin.
Vitamin A.
What is this?
Sir, KF.
Anybody?
Cave ring.
Cave ring.
This is a classic cave. The very classic cave ring. You can see the classic cave ring. Now, is it pathognomonic of Wilson disease?
No, sir. Even in a chronic
What does
liver
pathognomonic
disease.
mean? Pathognomonic means it's seen in only in Wilson disease. It's not
Wilson's
like
disease.
that. It may be seen in any condition in which there's a prolonged cholestasis.
Yes.
In any condition in which there's a prolonged cholestasis. For example, a child with PFIC. Okay? If he leaves Alagil syndrome, any child with prolonged jaundice called a pseudo, something like a cave ring. Okay. So then they may ask, what are the layers of the cornea anatomy? How many layers are there?
5 layers.
One layer has been recently described. Traditionally, we have been teaching there are 5 layers. Recently, one more layer has been described. What are the layers? The first layer is the. Can you start with epithelium?
Epithelium. Then
second layer is Bowman's layer.
Bowman's layer.
Third layer is the substantia propria or the stroma.
Stroma.
Fourth layer is the
Descemet's membrane.
Fifth layer is Duval's layer. This is a recently described layer. This is not given in most of the textbooks. And lastly, we have the endothelium. What should you know about this? Where is cave ring seen?
Descemet, sir.
Descemet's. So the cave is actually KFD. What is KFD?
Casanor forest disease.
KFD is Casanor forest, and that's also the tip for Descemet's membrane. KF, you write a hyphen. KF ring is in the Descemet's membrane. Okay.
Yes, sir.
So KFD is Casanor forest disease. KF, if you write a hyphen and then D, KF ring is seen in the Descemet's membrane. Now, how to differentiate KF ring in Wilson disease from pseudo KF ring seen in cholestatic liver disease? So these are some of the differences.
Yes, sir.
Okay. For example, the KF ring in Wilson disease may be seen even without Schiltlam examination, but a pseudo KF ring is seen only with Schiltlam examination. And it's seen in the stroma. Pseudo KF ring is usually seen in the stroma. The ring will be usually complete in Wilson disease. It is incomplete and thin in pseudo KF ring. Color may be slightly different, golden brown, yellowish green. No relation to serum bilirubin in KF ring in Wilson disease. Whereas in pseudo KF ring, it's seen when the serum bilirubin is more than 20 mg/% for a period of more than 6 weeks. So suppose somebody has got a prolonged jaundice for more than 6 weeks, the serum bilirubin is more than 20 mg/%. Then it's possible that some of the bilirubin may be deposited in the stroma. Remember, it is a stroma. So the KF ring may disappear with treatment for Wilson disease, whereas the other one will disappear when the serum bilirubin becomes less than 10 mg/%. Okay, so these are some of the differences between the KF ring and pseudo KF ring. Okay.
Yes, sir.
What is this? What is Fleischer's ring? The other one is Kaiser-Fleischer ring.
Yes,
what
sir.
is Fleischer's ring? What is Fleischer's ring? Anybody? It's not the pediatric problem. It's actually an ophthalmology problem. Seen keratoconus.
Yes, sir.
Keratoconus. What the relevance of keratoconus in pediatrics? It's one of the ocular manifestations of Down syndrome. So keratoconus may be seen in Down syndrome.
Alports.
And it's due to the deposition of hemosiderin in the substantia propria.
Yes, sir.
The Fleischer's ring is due to hemosiderin deposition in the substantia propria in the stroma. And what is the sign described in keratoconus? When the patient looks down, you get a Munson sign. Heard of that Munson sign?
Yes, sir.
Munson sign. The relevance in pediatrics is that Fleischer's keratoconus is one of the ocular manifestations of Down syndrome. Okay. Now, how will you demonstrate KF ring?
Sir, ideally, it has to be seen by a slit lamp examination.
So, ideally by motility can be so ideally by a slit lamp. This is a slit lamp apparatus of slit lamp examination. Sometimes, for example, here you can see without slit lamp. In advanced cases, especially neurological Wilson disease, you can demonstrate. You can see, we can visualize KF ring even without slit lamp examination.
Yes, sir.
Okay. That is without slit lamp examination. And once a student told me, sir, this is a biomicroscope is another name for slit lamp examination. Okay. So one student answered in the examination, said by naked man's eye examination. It's actually not naked man's eye examination, but the naked eye examination. Don't say naked man's eye examination. It's not pathognomonic. We already seen that it's not pathognomonic
Yes,
of Wilson disease. So it's seen in the
Decimates.
KFD means Chiasanophorus disease or KF ring is in the decimates membrane. That's a tip for that. KF ring is in the decimates membrane of the cornea. So what are the indications for slit lamp examination in pediatrics? This may be asked as a short note. What are the various indicators apart from a KF ring? What are the indications?
Sir, cystinosis, sir. Cystinosis, cystine crystals.
Cystine crystals, cystinosis. Anything else?
Sir, all
cataract,
cataracts,
like oil drop. For
galactosemia,
example,
yes.
oil drop cataract
Yes.
is very difficult to visualize otherwise. Scleritis, rheumatoid arthritis, you get scleritis. KF-ring,
uveitis.
cystine, uveitis,
Uveitis.
cystine crystals and cystinosis.
Cystinosis.
Lish nodules. Which condition you get lish nodules? Lish nodules are seen in which condition?
No, sir, neurofibromatosis.
That's a typical UG answer. That's a typical undergraduate answer. What is the postgraduate answer? Type 1.
Type 1, sir.
So postgraduate should say type 1 neurofibromatosis because you don't get it in type 2 neurofibromatosis. Type 1 neurofibromatosis. Then RP, retinal tear. So many conditions can be diagnosed by glaucoma. So it's a very important aspect of examination, and this may be as such a short note also in the theory for MD as well as for DNB.
Okay, sir.
What
sir,
type of cataract is in Wilson disease?
Sunflower cataract, sir.
This is a sunflower. Have you seen sunflower? So this is a sunflower. Who described this cataract?
Olaf.
Olaf, very good. Olaf cataract. So this is sunflower cataract described by the famous ophthalmologist Olaf. So sunflower cataract is also known as Olaf cataract. What else will you look for in the eyes of this child? You have seen so many things. What else will you look for in the eyes?
Sir, we can.
What is this?
Thickening of the
what is this
membrane of Schwalbe, sir. Posterior
This
embryotoxin.
is a posterior
Alagilis syndrome.
by slit lamp examination. So another use of slit lamp examination is posterior embryotoxin, which is, as you rightly mentioned, it's a thickening of the membrane of Schwalbe. Thickening of the membrane of Schwalbe thickening of the membrane of Schwalbe in Alagilis syndrome. That is posterior embryotoxin. Remember, it is a toxon, T-O-X-O-N, not toxin. What are the relevance of vertical gaze palsy in neonatal cholestasis?
Tyrosinemia, sir.
Tyrosinemia doesn't cause. Does tyrosinemia cause vertical gaze palsy?
No.
Which condition? You want a clue?
Niemann, yeah. Yes, yeah.
I'm trying to pick this thing. I'm picking this.
Yes, sir. It's a type C Niemann-Pick's disease.
Which Niemann-Pick will cause
type
vertical
C,
gaze palsy?
Type C.
So Niemann-Pick C is characterized by vertical gaze palsy and gelastic cataplexy.
Yes,
so these are the in addition to neonatal cholestasis, there may be vertical gaze palsy as well as gelastic cataplexy.
Yes,
so these are the features of Niemann-Pick type C. Okay. What's the importance of fundus examination in neonatal cholestasis?
Macular flex.
What is this?
Salt and pepper. Rubella.
Retinitis pigmentosa.
Sorry, retinitis pigmentosa. Dark color, yes.
Right. So this is retinitis pigmentosa. What is the relation? Where do you get retinitis pigmentosa and neonatal cholestasis? Retinitis pigmentosa and neonatal cholestasis. What is the
Zellweger, sir.
Zellweger syndrome. So you get retinitis pigmentosa and Zellweger syndrome. Okay. Anything else? What is that?
Drussens.
Is it visible? Yeah. What is that?
Cherry red spot, sir.
That is cherry red spot. Okay. Where do you get cherry red spot?
Niemann-Pick.
Niemann-Pick disease, you can get cherry red spot. It's also known as Tay spots. Good. What is this?
Drussen.
And what is this? This is anybody, what is this?
Drussens, sir. Drussens.
This is a normal fundus.
Okay,
this is a normal fundus. This is a normal fundus. Okay. This is a normal fundus. And what is this? You can see the chalky white disc. So this is optic atrophy. So this is in contrast to the normal pink fundus. This is optic atrophy. So where do you get optic atrophy and near to cholestasis? So this is a normal fundus. The other one is optic atrophy. Where do you get optic atrophy? How do you call it optic atrophy in name? So it's a condition called septo-optic dysplasia. Septo-optic dysplasia. It's also known as Demorse's syndrome. Septo-optic dysplasia is also known as Demorse's syndrome. This can cause near to cholestasis and so many other problems. Okay.
Yes, sir.
Now, a question to you: how many of you have got urine ophthalmoscope? Almost 85 people. How many have you? Rennie, have got an ophthalmoscope of urine?
No, sir.
Do you have an ophthalm? You don't have. I'm sure you will be having this. Most of the pages will be having an iPhone. You know, the iPhone costs anything from 50,000 rupees to 1 lakh rupees, whereas an ophthalmoscope costs only about 10,000 rupees. And ophthalmoscope is a lifelong possession, whereas an iPhone you will change every how many years? 3 to 4 years you will have to change of iPhone. But this is very important. So is essential for all PGs. You should never depend upon your hospital. Don't depend upon Amala PGs, Amala Hospital, or your own medical college. So all of you, please buy an ophthalmoscope of your own. But this is a famous dictum. You know this dictum? Only if you have seen thousands of normal fungi can you ever pick up an abnormal fundus. You cannot suddenly die. That's the reason why you didn't pick up that abnormal fundus, normal fundus as well as the optic atrophy. Only if you have seen thousands of normal fungi can you pick up an abnormal fundus. So buy an ophthalmoscope of your own immediately at the earliest. Okay, and then what will you do with ophthalmoscope? You examine your roommate's fundus. Or you examine any patient who is coming to you, a patient with abdominal pain. He's not very sick. But in COVID time, it may be difficult, but even otherwise. You can examine your friends, your roommates, your classmates, maybe even your teachers, doesn't matter. So practice on your friends and all patients. The lifelong possession, unlike iPhone. iPhone you need to change every 3 to 4 years. Okay, Renu, will you buy an ophthalmoscope?
Yeah, definitely, sir.
Okay, right, thank you.
Thank you, sir.
Now what is this? This is one of my patients.
Xanthoma.
Very good. That is xanthoma. See? You can see 2 types of xanthoma. The same patient. What do you think? You can see the lichenification of the skin because of the intractable pruritus. This child has got intractable pruritus. You can see the lichenification. Then what could be the diagnosis here? I'm not showing the photo of the child, but what could be the diagnosis here? Such intractable pruritus.
Sir, hereditary.
This is actually Alagil syndrome. This is actually a child with one of my own patients with Alagil syndrome. I'm sure my PDs have seen this child just a few days back in KMCT Medical College. What is the typical histopathological find? If you do a biopsy, what will you find? Xanthoma, if you do a biopsy, what will you find? Srijit, anybody in the chat box? What is the histopathological finding of Srijit? Anybody in the chat box with the correct answer?
No, and cholesterol.
The cells are 210 giant cells. The correct answer is 210 giant. Anybody written 210 giant cells?
No, sir. No, sir. No answers.
Okay. 210 giant cells may be seen. These are the giant cells seen in xanthomas. So this child is actually got Alagil syndrome. I'm not showing the face of the child because for obvious reasons. Yeah, what is this? And what is its significance in neonatal cholestasis? What are you seeing here? And what could be the diagnosis? Renu, what are you seeing here?
Sir, this
okay, which chromosome anomaly this finding may be seen in the neonatal period?
Turner syndrome.
Turner syndrome and sometimes the Noonan syndrome. Okay. In neonatal cholestasis.
Hello.
Neonatal cholestasis.
Sir, large for gestational age, sir.
Yeah,
Agnes syndrome. Agnes syndrome.
Oslo is the capital of? Oslo is the capital of?
Norwegian.
Norway. So Norwegian
state.
Norwegian cholestasis. Sorry, Norwegian cholestasis. Or Agnes. It's also known as Agnes syndrome. So this is, you can see that it's actually a non-pitting edema, non-pitting lymphedema, classically described in Agnes syndrome. The other condition, of course, is Turner syndrome, Milroy's disease, Noonan syndrome, but they do not usually have cholestasis.
Okay, sir.
So what is this? Is a few words about Agnew syndrome. It's a condition with episodic cholestasis. This term may be asked an exam. Episodic condition, genetic syndrome which causes episodic cholestasis and which has got a better prognosis is Agnew syndrome. Relatively good prognosis. So neonatal cholestasis with a relatively good prognosis. Suppose somebody asks you that question, your answer should be Agnew syndrome, which is also known as Norwegian cholestasis. Okay, right. Renu, continue.
Sir, the chest has got a normal shape, no rachitic rosary, no precordial bulge.
Again, there is unusual to get a rachitic rosary in a 75-level baby.
Yes, sir. Okay. Then abdomen is not distended, no dilated veins, no visible peristalsis or masses, no umbilical hernia. Hernial orifices are normal.
What's the umbilical hernia?
Sir, congenital hypothyroidism.
Congenital hypothyroidism, very good. Congenital hypothyroidism may cause a hernia
then,
and cholestasis.
External genitalia is that a female, normal, no label additions. Okay. Anal orifice is normal, limbs are normal, no bowing, spine normal. No telangiectasias, vascular malformations or neurocutaneous markers.
Now, reduce neurocutaneous markers. I was wondering, what do you mean by what is the relevance of neurocutaneous markers? What did you have in your mind? Maybe something which I do not know. Neurocutaneous markers, and rare as well. Raynaud syndrome, something like that.
No, sir.
Actually, no. Unnecessarily the examiner may ask him about neurocutaneous. Of course, this is one method of leading the examiner.
Okay, sir.
You can always express it now, but I think this is not required. And this particular junction is not required. That's the reason why I marked it in.
Okay, sir.
Okay, continue.
Abdomen on inspection. Abdomen is not distended.
Abdomen is not distended. It's a very important statement. This abdomen is not distended. So the question is, what are the cause of abdomen distension in children?
Sir. Most common, sir.
Usual answer will be fatty, fertile female of 40 with fetus in adults.
Gaseous distension.
Gas. Not happy with gas. True abdomen, important, significant abdomen distension. Number one is a massive organomegaly. A child with a massive hepatosplenomegaly. For example, a storage disorder. They may present with a true abdomen. Second one is ascites, severe or massive ascites. The third one is a lump in the abdomen. Wilms tumor. These are the three most important causes of a significant abdomen distension in the pediatric group. Massive organomegaly, massive ascites, or a lump in the abdomen like Wilms tumor or neuroblastoma. Okay?
Sir. No dilated veins or masses, no umbilical hernia or discharge. Abdomen, all quadrants move equally with respiration. Hernial orifices are normal. Liver span is 5 cm. No splenomegaly, no dilated veins, no renal mass palpable.
So liver is palpable 4 cm below the right cushion margin. Firm in consistency.
Yes, firm in consistency, smooth surfaces, well felt margins. Liver span
is the normal liver span at birth?
So newborn liver span.
The normal liver span at birth is but 4 to 5 centimeters.
4 to 5 centimeters.
You have written the liver is palpable 4 centimeters below the right cushion margin. But the liver span is only 5 centimeters. So this do not tally. If the liver is palpable 4 centimeters below the right costal margin, then the span should have been about 8 to 9 centimeters. You got my point?
Yes, sir.
Okay. The usual liver span, the size liver span at this age is about 4 to 5 centimeters. If it is palpable 4 centimeters below the right costal margin, then the span should have been actually 9 centimeters.
Okay, sir.
Okay. When you written no dilated vein during palpation, that's not significant. Dilated veins at the inspection fine.
Inspection, okay.
Palpation, you can find out the direction of flow during palpation, not during, may not mention no dilated vein during palpation. And so I am not happy with the liver span. Now, how do you find out the span of the liver? This is something which may be given as an OSCE, and students do terribly in finding out in the hepatomegaly. So how will you find out the span of the liver? What is the first step?
First, we have to.
First, you have to get a Rappo. You have to warm your hands. Rappo, as usual. Rappo, warm your hands. The next step is the next most important step is They
Sir,
finding out the midclavicular line. You should always find out the midclavicular line. Because
sir.
you say that the liver is palpable 4 centimeters below the right cross margin in the midclavicular line, but no one ever cares to find out the midclavicular line. So always draw it's very easy to draw the midclavicular. With a tape, you can very easily, just takes a few seconds. So draw the midclavicular, find out the midclavicular line and draw it. Second one is what's the second step?
So
second step is to find out the angle of Louis. Okay. Second step is to find out the angle of Louis. So you tell the examiner that I will find out the angle of Louis, and the space below is the second space. Okay. So you find the second right integral space, right? Then what will you do? Then you percuss down like this. Okay. You percuss down, and then you find out the upper border and the lower border of the liver. Then all the children you do tidal percussion to make sure that it is the liver. I'm sure you know about the tidal percussion. Because tidal percussion will be difficult in this baby, but it's possible when the baby is crying. Anything is possible in clinical medicine. A newborn baby, when it's crying, you can do tidal percussion. Anyhow, you find out the upper border and lower border. Okay. Now, how will you mark it? Suppose you have found out the upper border of the liver. How will you mark it? With what will you mark the upper border of the liver? Dot pen or ink pen? Always use chalk. It doesn't look nice. Suppose somebody is drawing on your abdomen, it doesn't look nice, especially with a pen. The other problem is, suppose you mark with a pen. What are the consequences of marking with a pen? Suppose you say you mark 2 centimeters lower border of the liver, 2 centimeters below the right costal margin. Okay, you're happy, you draw a line there and you go away. The liver may be actually palpable 10 centimeters below the right costal margin. So what happened in the next patient? The first candidate is already failed because he said 2 centimeters. Then your friend is coming in and he is also very happy saying that it is 2 centimeters below the right costal margin. So that the consequence is that you will fail not only yourself but also your best friend who is coming next. So never use a pen to draw. Always use chalk. So always use chalk. Have you ever carried chalk to the examination hall? I don't think so. So always carry chalk. And remember to rub it off before you are leaving. Even if you are using the chalk, you should rub it off before you are leaving. Okay?
Yes, sir.
Never use pen. You should never use pen to draw. Percussion.
Tympanic percussion. Tympanic not heard all over the abdomen. No shifting dullness.
What are the signs of ascites?
Sir, to be elicited, first
what
is...
are the signs? Can you mention some of the signs of ascites?
Yes, sir. Puddle sign.
We were very happy when they started with puddle sign. It's a very rare sign. Have you ever demonstrated puddle sign in pediatrics?
No, sir.
One of the most difficult signs which never be elicited in pediatrics. Maybe I ask an examination. It's very difficult to demonstrate puddle sign.
Knee elbow position. Then
shifting dullness.
Shifting dullness.
Flank dullness, shifting dullness, fluid thrill. Okay.
Fluid thrill.
Horseshoe dullness. These are the signs of ascites. Okay.
Now, auscultation, bowel sounds are heard all over the abdomen. No hepatic or renal bruit. Other systems are normal. CVS examination.
Cardiovascular system in there. You will always mention that. What is the importance of examination of cardiovascular system in neurocholestasis?
Sir, peripheral pulmonary artery stenosis can be seen in congenital rubella syndrome and also in.
What are the cardiac lesions of congenital rubella syndrome?
Sir,
what's the most common one?
Pulmonary stenosis, sir. Peripheral pulmonary stenosis.
The most common one is PD. The most common is patent ductus arteritis. Yes, sir. Followed by peripheral pulmonary stenosis.
And then even in Araguela syndrome, BST. Pulmonary stenosis.
PD, peripheral pulmonary stenosis, and BST. These are the cardiac lesions of congenital rubella syndrome or Gregg syndrome.
Yes, sir.
Alagal syndrome. What is common to Alagal syndrome and the congenital rubella syndrome?
Peripheral pulmonary stenosis.
Correct. So peripheral pulmonary stenosis may be seen in both Alagal syndrome and congenital rubella syndrome.
Yes, sir.
Now we have finished the history exam. Now you have to summarize it. Okay.
Yes, sir.
Are you ready for summary?
Yes, sir.
So summarizing a case is one of the most difficult aspects, and most of the students do horribly when you're asked to summarize a case. Okay. So summarizing a case is an art. This has to be perfected. How do you perfect? You need to do it repeatedly. It is often compared to a European lady's micro mini skirt. It should be very short, should be exciting, and should reveal everything in just a few seconds. Just a few minutes, it should be. So everything should be ready in a few minutes. Now let's see what Renu's summary is. This is Renu's summary prepared by Renu and sent to me. Okay. Is it like a micro mini skirt? Renu, it's actually like a very, very, very long skirt. See, very long. This should be confined to just a few sentences because you have to roll out all unnecessary things or trivia. No trivia. So I have summarized for her. Let's see how that is. I just written 75-day-old female child and girl born to non-consanguineous parents, birth weight 2006 grams, presence with intermittent pale stools, colitis jaundice and day 30, along features a coagulopathy. Is it a short skirt or long skirt? It's a short skirt. So there should be as short as possible. Just a minute. And the battery board. Just a minute, my battery is getting run out.
Renu, do you have the pictures of the child?
Sir, I don't have the picture, sir.
Okay.
Just a minute. Okay, I'm sorry about it. Hello, can you hear me? Renu?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. You're audible.
Okay.
So
So
differential,
just
differential
summarize this case
diagnosis.
and what is the differential diagnosis now? What is a differential diagnosis? So here differential diagnosis are number one, biliary atresia, irritable hepatitis, inborn errors of metabolism, sepsis. So these are the 4 differential diagnoses sent by Renu. So what are the points in how do you discuss this case now? Biliary atresia. What are the points in favor of biliary atresia? Number one is gender.
Female.
You know that first of all, I would like to say that sometimes it will be very difficult to come to a diagnosis. It may be anything. Okay. So what are the points in favor of biliary atresia? One point is that the gender may, or that you can say that gender may be suggestive. It's not a very good argument. It's not a sick child. Remember that a child with biliary atresia may not look sick initially, so it's not a sick child. Isolated firm hepatomegaly. Initially in biliary atresia, there may be a firm hepatomegaly. Splenomegaly is late. Only when there is a hepatic fibrosis, cirrhosis will lead to splenomegaly in biliary atresia. So this child, 75-day-old baby, has got only an isolated firm hepatomegaly, right? So these are some of the points in favor of biliary atresia. And there are no features of indirect infection, no congenital heart disease, no cataract, etc. Absence of these features. Points against that. One of the strong points against the diagnosis, this child has got
the child has.
Okay, that is a very strong point against the clinical point against the diagnosis of biliary atresia. Because in biliary atresia, you get a classic persistent pale or the markedly pale stool. So that's the point again. But I would like to mention once again that sometimes it will be extremely difficult to differentiate the various types of cholestatic syndromes. And the birth weight. The birth weight will be usually around 3 kilograms. This child is around 2.6. Okay. Neonatal hepatitis, any point in favor of neonatal hepatitis, intermittent colic stools, absence of microcephaly cataracts are not very strong points. Okay, and you can say that it's relative rare in families. No splenomegaly. Usually neonatal hepatitis present with hepatosplenomegaly. Okay, these patients present with early hepatosplenomegaly. Now, how are the basic investigations this child you would like to do? What are the basic investigations?
Sir, at the first step, we'll do a
like
CBC,
CRP. CRP, why?
Sir, to roll out sepsis.
That's it. See, what about CBC? You want to know about the hemoglobin status of this
hemoglobin,
baby.
yes,
okay.
Yes,
He's got bruise. Okay, easy bruisability. You would like to definitely would like to know. But sometimes there may be internal bleeding also. Definitely, you would like to know whether the baby is anemic. Such a simple investigation will be very important.
Anemia.
Then it will help you to tell about thrombocytopenia. What are the causes of thrombocytopenia in a baby with neonatal cholestasis? It may be due to intrauterine infection. Or maybe due to hypersplenism due to early portal hypertension. Some of these babies that tend to develop portal hypertension quite early. Unusual, but they can develop hypersplenism. Even the neonatal period, but early they may develop hypersplenism. So these are some of the causes of thrombocytopenia in cholestasis. What about leukopenia? What is the significance of leukopenia in a baby with neonatal cholestasis? Leukopenia may be a sign of sepsis. Only leukocytosis, but remember that newborn babies, leukopenia may be suggestive of sepsis. So even a simple CBC and CRP will be very helpful. Even simple basic investigation will be very useful in the evaluation.
Yes, sir.
Then PTANR, okay, may be prolonged. Suppose it is prolonged, it indicates decreased hepatic synthetic function or vitamin K deficiency. Maybe due to simple vitamin K deficiency, and a short of vitamin K will correct it. So yes, if a prothrombin time is corrected with vitamin K deficiency, you should be very happy. It's only due to vitamin K deficiency. Then you should have full LFT. So these babies may, the transaminase may be mildly elevated, and alkaline phosphatase will be very high,
including GGT.
So what is the most important biochemical investigation when ALP is very high? What is the most important biochemical investigation when ALP is very high? You already mentioned that.
Sir, GGT. GGT has to be done.
GGT will be usually high along with ALP.
ALP.
But there are several conditions with a normal or even a low GGT. What are these conditions?
Low GGT conditions are classically hereditary, progressive familial intrahepatic cholestasis.
Which types?
Sir, 1 and 2. 3 usually
actually,
have elevated
1, 2,
GGT.
4, 5. Recently, the other types have also been described. 1, 2, 4, 5. 1
yes,
to 6. So
yes,
1, 2, 4, 5, and 6, PFIC. It may be normal or low. Then we have Agony syndrome. We already mentioned the northern cholestasis. ARC, we'll come to that later. What is ARC?
Sir, arthritic process, renal
dysfunction
and
cholestasis.
Cholestasis. Yes.
Then bilateral synthetic
disorders.
Disorders with a relatively good prognosis. BRIC. What is BRIC?
Benign recurrent intrahepatic.
Correct. Benign recurrent intrahepatic cholestasis. These are some of the conditions. Some of the conditions with a low GGT or normal GGT in spite of a very high ALP.
So,
what is the role of ultrasonography? Is it important? Ultrasonography, is it important? Ultrasound is one of the most useful non-invasive investigations. What about, suppose you are as a researcher, you are sending a baby for USC. What
yes,
precaution will you take?
Sir, the child should be free from milk-based feeding for 4 hours at least prior to ultrasound.
At least 4 hours, the child should be fasting. The child should be fasting for at least 4 hours.
Even then, if it's not, structures are not visible, we have to repeat it again. With the same.
So after suppose the baby is crying, what will you do? Suppose the baby may be hungry, then you can give some glucose feed. Doesn't matter. You may have to give some glucose feed. Doesn't matter, but should not give
milk based.
If you give breast milk, what will happen? Due to the presence of lipid in the breast milk, the cholecystectomy will be released, and that will cause contraction of the gallbladder. So it will be difficult to visualize the gallbladder.
Yes, sir.
Remember that a distended gallbladder is a strong point against the diagnosis of biliary atresia. If the gallbladder is well imaged and distant, it's a strong point against the diagnosis of biliary atresia. Sometimes, very rarely, even in biliary atresia, gallbladder may be present, but
Type E,
usually a distended gallbladder, the presence of a distended gallbladder is a strong point against the diagnosis of biliary atresia.
Yes, sir.
Then if there is time, the radiologist may ask the mother to give a feed to visualize the contraction. Is the GAB contracting during breastfeeding? That's also possible. Then other thing is that you can diagnose choledochal cyst. Okay, choledochal cyst can be diagnosed for this condition. Choledochal lithiasis, even though rare, that's also possible. Choledochal lithiasis can be diagnosed, and you can diagnose this relatively benign condition, infiltrated bile duct syndrome. How? The distal bile duct will be tapered abruptly, that will be abruptly end, but there will be intrahepatic biliary radicals dilatation. It's called IHBRD. Intrahepatic biliary radicals will be dilated. That is a strong point against the diagnosis of biliary atresia and for the diagnosis of infiltrated bile duct syndrome.
Okay.
Okay. Then you can diagnose other conditions, polysplenia, situs inversus. And this is a part of what is called BASM. Heard of this condition? What is BASM? BASM? Anybody? What is BASM? BASM? That's actually an acronym. Biliary atresia splenic malformation syndrome. BASM is actually biliary atresia splenic malformation syndrome. It's a part of this, the type of biliary atresia in which polysplenia and situs inversus may be seen. So USG is going to be extremely useful, but the resident, pediatrician should make sure that the baby is sent to the radiologist only after at least 4 hours fasting. Suppose you get Rino already mentioned a sick baby, a baby with failure to thrive or pulmonary hepatic failure. How will you evaluate? First of all, you should rule out sepsis because it's a very well treatable condition. Sepsis is a very well treatable condition. Then look for non-glucose reducing substance in the urine for galactosemia. Non-glucose reducing substance for galactosemia. High ferritin. Suppose the ferritin is very high.
Hemophagolymphocyte. Yes, sir.
What is GALD? What is GALD? GLD?
Sir,
We get a short note on GALD.
Alloimmune liver diseases and hemophagocytic
lymphohistiocytosis. Old name is neonatal hemochromatitis and HLH, high ferritin. Alpha fetoprotein already mentioned that extremely high in type 1 tyrosinemia. Then another point is high serum lactate. Where do you get high serum lactate? Mitochondrial hepatopathy. In the mitochondrial hepatopathy, you get high serum lactate. And there are specific tests for GALD. What is the specific test for GALD? Very useful, specific test, very useful, relatively simple test for diagnosing GALD. What is anybody?
Mucocutaneous biopsy.
Pardon? Yes.
Mucocutaneous biopsy, sir.
Which biopsy?
Mucocutaneous.
Lip biopsy. That's right. Lip biopsy is a very simple procedure for diagnosing GALD. MRI can be done, but you know that MRI is very difficult in a small baby. So this is a very simple test for diagnosing GALD. You may get a short note on GALD. You can say write about a lip biopsy, which will show minor salivary glands filled with hemocysteine. Minor salivary glands in the lips will be filled with hemocysteine. What's the role of bone marrow examination?
Hemophagolymphohistiocytosis.
HLH can be diagnosed by bone marrow. So these are the investigations which may be required when the baby is sick.
Yes, sir.
HLH. Bone marrow for HLH. Okay. So neurocholesterolemia syndrome with hypoglycemia, we will already see that galactosemia, type 1 tyrosinemia, hypopituitarism. Okay. What are the second line investigations? If suppose the initial workup is inconclusive, then you can do a TORCH screen. Remember, TORCH screen is extremely expensive. Sometimes it may be possible for you to come to a diagnosis even without TORCH. And TORCH is not really available in most of the countries, most of the centers, most of the places in our country. Sometimes it may be possible to diagnose without TORCH screen. So the initial workup is inconclusive, you can do a TORCH screen. Then you think of other conditions like type 1 tyrosine, you do succinylacetone for tyrosinemia, gallwork, cystic fibrosis, serum cortisol. Sometimes serum cortisol, suppose you can't come to a diagnosis, always think of the possibility of an undiagnosed hypopituitarism. So an 8 a.m. cortisol will be extremely useful in such a situation. What is jaundice chip? Heard of jaundice chip? Do you know what is jaundice chip? Heard of anybody what is jaundice chip? So jaundice chip is a chip-based genetic sequencing for inherited intrahepatic cholestasis. Nowadays, it's possible to diagnose so many of these conditions. Genetic diagnosis is possible. For example, JAG1 gene. Suppose you demonstrate JAG1 gene. What is the diagnosis? JAG1 gene for Alagil syndrome. Okay. ATP-B81 gene for PFIC1. PFIC1, the gene is ATP, that's called violent disease. ABCB11, that is PFIC2. PFIC2. ABCB4, that is PFIC3. ABCB4 is a PFIC3. Serpina, this is a very important question for us. Serpina1. Serpina1 is a gene for which condition? Srijit, anybody has written in the chat box? Serpina1 is the gene for which condition?
Nobody has written.
14th chromosome, long arm of the 14th chromosome.
Sir, alpha 1 and
alpha 9 deletion.
Yes, sir.
Alpha 9 deletion. Serpina1. I hope you are not familiar with jaundice. You make a short note on jaundice chip.
Yes, sir.
Can you go to the next slide? You're written? Shall I go to the next slide?
Yes, yes, yes.
Oh, that's actually the end of this program, not the end of this program. Her presentation is over. Okay. Now, shall we go for the revision questions?
Yes, sir.
You ready?
Yes, sir.
This is going to be interactive session. Sridhar?
Yes, sir.
This is going to be interactive session. You can stop me at any time you want.
Yes, sir.
When the time is over, just let me know. There are lots of questions here. So, most of the questions we would already discussed. Yeah, there may be some new questions also. Okay. So, what is neonatal cholestasis? What is the definition of neonatal cholestasis? This is important because you feel that it is the first. It's not the first 28 days. The actual refers to cholestasis liver disease present at birth,
even up to 6
or
months.
dealt with in the first few months, up to 3 to 6 months of life, rather than strictly adhering to the neonatal period of 28 days. So you can't say that this baby is 40 days. You can't call it as a neonatal cholestasis, or you can't say that this baby is 5 months neonatal cholestasis. No, it's quite possible. Especially so because you have to diagnose. You have to do surgery for biliary atresia before 2 months. Okay, so this is the definition of neonatal cholestasis. So what is neonatal cholestasis? High colored urine, staining of diapers, pale stools, conjugated bilirubin more than 1.5 to 2 million person, or the conjugated bilirubin exceeds 20% of the total bilirubin. What are the causes of neonatal infant cholestasis? Causes can be classified into extrahepatic and intrahepatic. Extrahepatic, we already see in all these biliary atresia, cold duct. These are surgical causes, mainly the surgical causes. Biliary atresia, cold duct cysts, these are the most important ones. But they can also be spontaneous perforation, the bile duct, cholelithiasis, IBS. Intrahepatic causes we have discussed in detail already. Metabolic. Remember that PPIN associated cholestasis is important. Drug-induced cholestasis is possible. Chromosome anomalies, metabolic disorders, various types of infections. I'm sure you'll be knowing all this. Shall I go to the next slide? Yeah. And miscellaneous causes, Alagil, PFIC, Summerskill, Agnes, and HLS. These are some of the conditions which cause neonatal cholestatic syndromes. What's the most important clinical examination? Most important, I underscore most important clinical examination in CLD in the periphery. Suppose you are working in the periphery. You can't do any investigation. You are the only pediatrician, no lab setup, no ultrasound. What simple test can you do? You can examine the visual examination tool for 3 days. Okay, this is very important. Suppose the child, the mother is saying that she is passing high-colored urine. You have to examine the stool of the child for at least for 3 days. It will be possible to make a diagnosis. Please should suspect cholestasis. So visual examination for the stool. Sick baby, we already seen that type 1 tyrosinemia, galactosemia, HLH, and mitochondrial hepatopathy. So these are the differential diagnosis when you are a sick baby with neonatal cholestasis, like type 1 tyrosinemia, galactosemia, HLH, and mitochondrial hepatopathy. What simple investigation helps to diagnose? What is this investigation?
Sir, this is a lip.
This is actually a revision question. What is this investigation?
Lip biopsy.
This is a lip biopsy.
Lip biopsy,
In fact, I had sent this question to my PGs. Remember Jidesh and Kavya? This is actually lip biopsy. You take a biopsy from the lower lip. It's a very simple procedure. There are several minor salivary glands in the lip, and they will be filled up with hemocytin. So, demonstration of some minor salivary glands in the lip, which are filled with hemocytin. It's a very simple test to diagnose GLD. Liver biopsy will be very difficult, risky due to coagulopathy. So instead of doing liver biopsy, you should try to do a lip biopsy. You can coax your pediatric surgeon to do this simple procedure. You can be done under local anesthesia. It doesn't require it's a very simple procedure. Okay. Either term extrahepatic biliary atresia, correct. We already seen that it's not extrahepatic biliary atresia. It is taking place not only the extrahepatic biliary, but also the intrahepatic biliary is sclerosed or obliterated. So just say biliary atresia, not extrahepatic biliary atresia. What is physiological cholestasis? Heard of this term? Physiological cholestasis. You see in preterm baby, you know that there are several proteins, transport proteins involved in the transport of bile acids, like NTCP. This may be asked as a short note: NTCP, bile salt export pump, etc. So in preterm babies, these proteins are not expressed properly. So preterm babies are not able to transfer or secrete bile acids. So they are prone to develop some amount of cholestasis, which is called physiological cholestasis, which will subside of its own. This is a benign condition, usually seen in preterm babies. But these proteins may be as such a short note, NTCP and BSEP. What is transient cholestasis? Any perinatal disease causing fetal congestive cardiac failure. So blood supply to the liver is decreased. So there can be some amount of cholestasis. Or there may be fetal arrhythmia. Or neonatal lupus can cause a congenital heart block. In such a patient, if a steroid is given, neonatal lupus, if you give steroid, that cholestasis will completely resolve almost immediately. So that is a transient cholestasis. And congenital hypothyroidism, cholestasis will recover with L-toxin therapy, thyroxine replacement therapy. So this is what is known as transient cholestasis. Okay. This child was referred to me with a diagnosis of biliary atresia. It's actually not biliary atresia. What's the diagnosis? Let's just look at this child. Can you spot the diagnosis? Can anybody spot the diagnosis?
Sir, umbilical hernia, sir.
The umbilical hernia. Look at the tongue.
Coils facies, yes, sir.
Coils facies. This is hypothyroidism. This child just had hypothyroidism. This was not biliary atresia. He became all right with L-toxin therapy. This is another example of transient cholestasis. But biliary atresia is entirely different. What are the findings here? What are the findings in this child? What are the findings? Quick.
Umbilical hernia,
You can see the massive distended abdomen due to ascites. Massive distended abdomen is a transverse incision due to the secondary ascites operation. Dilated veins. Can you see the dilated veins?
Sir.
And these are the incision hernia. These are the findings. What are the consequences of cholestasis? Suppose there is a cholestasis. What are the effects? What are the consequences? There will be retention of all substances which are normally excreted or secreted in the bile. For example, retention of all substances normally excreted in the bile. For example, when bilirubin is not excreted, that will come back to the bloodstream causing what? Jaundice.
Jaundice.
Okay. When that causes jaundice. When bile acids cannot be excreted, that will cause
pruritus, sir. Pruritus.
Malabsorption of fat-soluble vitamins and steatorrhea. The bilirubin, jaundice, bile acid, pruritus. For malabsorption of vitamins A, D, and K, will cause some congenital hemorrhage, okay? Bleeding like this. Cholesterol is retained, that will cause xanthomas. You remember the other child? This is our child with like this syndrome. Xanthomas. Name the countries the highest incidence of biliary atresia in the world. Number one, number two.
Taiwan and Japan.
Japan, what's the incidence? 1.04 per 10,000. Taiwan, it is even more, 3.7 per 10,000. In European countries, only 1 in 12,000 to 18,000. Just 1 in 18,000 in Western Europe. The highest incidence is in Taiwan with almost 3.7 per 10,000 babies. Okay. So the basic distinction that the pediatrician has to make is between extrahepatic disorders, which may require surgery, from intrahepatic disorders, which do not require surgery, medical versus surgical. Okay. And always rule out treatable causes like transient cholestasis, sepsis, galactosemia, endocrinopathy is like hyperpituitarism. So is surgery versus medical treatment, extrahepatic versus intrahepatic. When to suspect, whenever the mother says that the urine cycle with staining of diapers, urine cycle with staining of diaper, never discard this mother's comment. This is going to be very important. Or persistent or even intermittent pale stools. After the passage of meconium, if the baby has got pale stools, always think of cholestasis. Whatever is the cause of colitis, there has to be some amount of cholestasis. What type of jaundice is this? You can see this is high-colored urine and pale stools. Classic example of cholestatic jaundice. Now, what are the misnomers in pediatric gastroenterology? Some of the misnomers in pediatric gastroenterology. One is
transaminitis, sir.
Come back to renal scleral icterus, HIDA scan, and extrahepatic biliary atresia. That we already mentioned. Extrahepatic. What about scleral icterus? So scleral icterus versus conjunctival icterus, which is correct. Who is this person?
William Osler, sir, father of modern medicine.
He's indeed Sir William Osler, the father of modern medicine. Here, the defined jaundice says yellow tinting of skin and conjunctiva. Yellow tinting of skin and conjunctiva, not sclera. Yes. And there are so many recent articles published in the esteemed journal saying that this is actually conjunctival icterus and not sclera. What is the blood supply of the sclera?
Sclera is an avascular organ, sir.
The sclerae are avascular. That means the bilirubin cannot be transferred to the sclera. Yes, instead, the bilirubin deposit in the bulbar conjunctiva overlying the sclera.
Adjacent to the
so ideally, that's called conjunctival icterus and not scleral icterus. Okay. But suppose you say in the examination you say conjunctival icterus, and the examiner doesn't like it. What will you do? Will you argue with the examiner? Never argue with the examiner, especially during examination. Always agree with the examiner. Okay. So you should not argue, sir, this is not correct, scleral icterus is not. It really doesn't matter because the eyes are yellow. That means there is icterus. But to the purist, it is actually congenital icterus and not scleral icterus. The other point is about technician scan, HIDA scan. You always say the child is sent for HIDA scan. What is HIDA? IDA means immunodiacetic acid. IDA actually means immunodiacetic acid. Okay? IDA means immunodiacetic acid. And this immunodiacetic acid was used initially for cardiac scintigraphy. Then they found that it was useful for liver also, and hence it was called hepatic immunodiacetic acid. And that was how the term HIDA was coined. So 3 decades back, we have stopped using HIDA. Okay, almost 30 years back, we have stopped using HIDA. What are we using now? Instead of HIDA, we are using a much better molecule called mebrofenin. Okay? Mebrofenin, both are lidocaine analogs. The mebrofenin is attached to technetium. Formerly, HIDA was attached to technetium. Nowadays we have attached mebrofenin to the isotope, which is technetium 99N. And this is injected. So ideally, this should be called mebrofenin scan, but it continues to be erroneously called HIDA scan. And of course, you should prime the child with phenobarbital or also deacetylcholic acid for 5 days. That is called augmented scintigraphy. So usually the isotope will be detected in the bowel in 1 hour. The isotope is not detected. Remember, it is not diagnostic of biliary atresia. Because in severe neonatal hepatitis also, the isotope may not be detected in the gut. But the presence of isotope in the gut suggests that this is unlikely to be biliary atresia. That is the importance. If we can detect the isotope in the gut, it is unlikely to be biliary atresia. That's all what we can say. So nowadays, we don't usually give too much importance for doing this mebrofenin scan. So you can see that this is a patient with neonatal hepatitis. You can see the isotope is present in the gallbladder and is present in the duodenum, the gut. Whereas in biliary atresia, look at the biliary atresia, it's not excreted into the bowel. Instead, it's going back to the bloodstream and it is excreted in the urinary bladder by the kidneys into the bladder. So the isotope will be present in the liver and the urinary bladder. That is suggestive. That may be suggestive biliary atresia or severe neonatal hepatitis. But if it is present in the gut, that means it is unlikely to be biliary atresia. Then what should you do as soon as you see a baby with
Vitamin K,
cholestasis?
sir.
Always
Vitamin K.
give, never forget to give a shot of
Vitamin K 5 milligram.
Which antibiotic should be avoided in cholestasis?
Sir, ceftriaxone.
Ceftriaxone, because this is well known for notorious to cause
Sludging and
pseudolithiasis, biliary
Yes,
sludge, and it may predispose to gallstones. So in a baby with already with cholestasis, it's better to avoid ceftriaxone. Neonatal cholestasis with large
Agonist
birth weight is
syndrome.
agonist syndrome or
Agonist and
not
not
with
with
cholestasis. What are the theories behind the pruritus of cholestasis? Somebody may ask in the theory exam. What are the theories? The whole theory is the bile salt theory, which irritates each
There are
latest theory is increased
newer molecules, sir.
ergic tone. So intravenous opioid antagonists or oral nalmefene may be effective. Any other theory? The latest theory is the
Autotaxins.
lysophospholipase autotaxin theory. So lysophosphatic acid is the potential mediator for the pruritus of cholestasis. So these are some of the latest theories behind the pruritus of cholestasis. How will you differentiate Alagille syndrome from congenital rubella syndrome? Both have got some similarities. So these are some of the differences between congenital rubella syndrome, also Gregg syndrome, Alagille syndrome. Failure to thrive is classically seen in congenital rubella, may not be seen in Alagille syndrome. Microcephaly may be seen in congenital rubella. Eyes, so many different findings, Cochiambrotoxon, myopia, keratoconus. Intellectual disability, deafness, common in the congenital rubella. Cardiac lesions may be similar. Peripheral pulmonary stenosis is common to both.
Yes.
Dysmorphism present in Alagille syndrome, no dysmorphism in congenital rubella. Butterfly vertebra may be present. And there are other features also. So you make it sometimes a short note on Alagille syndrome, and you should know everything about congenital rubella. So it's very important because it's a preventable disease. Okay.
Yes.
Can I go to the next slide, Renu?
Yes, sir.
What's the role of terminal ileum in absorption? What is the role of terminal ileum in absorption? Only two substances can be absorbed from the terminal ileum. What are they? Number one is vitamin B12. Number two is an acid. Which acid? What are the acids which you can drink? You can take, eat. You can't take sulfuric acid, hydrochloric acid. There are several acids like amino acids, retinoic acid. Okay. And this acid starts with B, so bile acid.
Bile acids.
Bile acids and vitamin B12 are absorbed from the terminal ileum. So there is a big role for the terminal ileum absorption of bile acids and vitamin B12. What are the receptors for absorbing vitamin B12? What is that receptor called? Why is vitamin B12 absorbed only from the terminal ileum? Vitamin B12 is absorbed only from the terminal ileum because there is a receptor. What is the name of the receptor?
Cubam receptor.
Cubam receptor. Suppose the Cubam receptor is absent. What is the condition called? Emerson-Grasbeck syndrome. This was Grasbeck syndrome. Causes a megaloblastic anemia. Cubam receptor, absence of Cubam receptor results in Emerson-Grasbeck syndrome. What's the importance of breast milk in neonatal cholestasis? You know that the breast milk is the best milk for babies.
Two types of jaundice.
Not that. Neonatal cholestasis, the importance is that breast milk fat is pre-emulsified.
Yes, sir.
It's a natural milk. So the breast milk fat is pre-emulsified. So it doesn't require bile acids. So it will be very well digested and absorbed by babies with cholestasis. You know that what's the emulsification is the process by which large fat molecules can be broken down into smaller fat molecules by bile salts, so that lipase can act on it better. So the breast milk fat is already pre-emulsified by God because it's a natural milk. Okay. What about cow's milk? That's also natural milk. That also will be pre-emulsified. Can you use it? Well, breast milk has not been boiled, whereas cow's milk has to be boiled. So when cow's milk is boiled, emulsification will be lost. Okay, cow's milk has to be boiled before we take it. So when cow's milk is boiled, emulsification will be lost. So that's the another advantage of breast milk and breast milk fat. So this is emulsification. Okay? We get a short note on emulsification. Now urine examination. How will you demonstrate urobilinogen? That's what urobilinogen.
Sir, Ehrlich's test.
Correct. Ehrlich's
Ehrlich's
antigen test. For bilirubin, simple test, a form
Fauch's.
test, or you can do a modified
Fauch's.
test. Modified Fauch's test. We already seen this is cholestatic jaundice. This is form test. When you shake, this is a normal urine. This is the urine of a child with hepatitis. Okay. When both are shaken, you can see that the bubbles in the normal urine will break down almost immediately. Whereas the bubbles in a child with hepatitis or cholestatic will persist even for 24 hours. The yellow color is due to the presence of bilirubin, and the stability is due to the presence of bile salts. This is called, it's a very simple test which you can do in your consultation room, that is even without going to the laboratory. Or in the ward also you can do this test. So tomorrow itself you can start doing the form test in your body if you got a patient with suspected hepatitis. Okay. Another revision question: cholestatic liver disease with normal GGT. We have already seen all this. BRIC is also known as Summer-Skill syndrome, ARC, and Agnes syndrome. Okay. So by this time, you should be able to answer most of these questions. That was my intention.
Yes.
So this is about PFIC. Please prepare PFIC as a short note, sometimes as an essay. So PFIC can be classified as normal or a low GGT, high GGT. This is PFIC 1, PFIC 2, PFIC 3. You should know the genes also. 18. The tip for the second PFIC 2 is that its gene is on the second chromosome. Okay. So gene of PFIC 2 is on the second chromosome. All genes are the long arm. That's the reason it's written as Q. The most severe type is PFIC 2. Pancreatitis is seen in which type?
PFIC 1, sir. PFIC 1.
In fact, we had a patient with the PFIC 1 just a few days back who had pancreatitis. It was admitted in Calicut Medical College, PFIC 1 with pancreatitis. Which disease peculiar to pregnancy may lead to NCS?
That.
Which disease peculiar to pregnancy may lead to?
No.
That is intrahepatic cholecystitis pregnancy. We have discussed that. That leads to PFIC 3.
PFIC 3.
Intrahepatic cholecystitis pregnancy leads to PFIC 3. Okay. Name the cholestatic symptoms with relatively good prognosis. One is Agnes syndrome. This is better. Most of the babies will become alive by 1 to 2 years. So Agnes syndrome, Norwegian cholestasis. Citrulline deficiency is another condition with a good prognosis. So pediatricians should be on the lookout for citrulline deficiency. Sometimes it may lead on to type 2 citrullinemia in adults. BRIC, as the term indicates, is a benign condition. Benign recurrent intrahepatic cholestasis. BRIC. It's also known as Summer-Skill syndrome. So these are the cholestatic symptoms with a relatively good prognosis. Okay.
Yes.
Then all the inborn, most of the inborn areas, the bile acid synthesis, they got a relatively good prognosis. Put the diagnostic value of serum lactate in neonatal cholestatic liver disease. Lactate, elevated lactate.
There are mitochondrial myopathies and
the higher mitochondrial hepatopathy. Screening test for type 1 thyroxine is
succinyl urinal
AFP. That's not a screening test. AFP is extremely high. 1.5 to 2 lakhs, extremely high value. Which torch hepatitis is the most serious?
CMV. Yes.
Most serious? No, it's not CMV. This herpes. Herpes may cause fulminant hepatitis. CMV may not cause fulminant. Herpes is always important because it may cause fulminant hepatitis. It's very well treatable. So that's the reason why Renu had mentioned about. I was very happy that she mentioned about the vesicles. Always look at vesicles. There are vesicles which the child should be put on acyclovir. Can cause fulminant hepatitis, can cause encephalitis, urgent treatment with acyclovir. So it's very important to diagnose herpes hepatitis. What are the symptoms of dysmorphism and cholestasis? Again, that's a revision
Ehlers
question.
syndrome, sir.
Ehlers syndrome,
Down
syndrome,
congenital hypothyroidism,
Zellweger syndrome, septopty dysplasia. RH incompatibility, relevance, we already seen that. That is
inspissated bile
duct syndrome. What is this? What is this? Shreyat, I think we have run out of time. Stop here. What is this?
Choledochal cyst.
That's a choledochal cyst. Choledochal cyst. This is the classic choledochal cyst. What is the triad of choledochal cyst? What is the classic triad of choledochal cyst? Choledochal cyst has got a typical triad. What is that? Jaundice, abdominal pain, and right hypochondrial mass. May not be seen in all patients, but this is a typical triad. So I'll stop now. Don't worry. Just a few slides more. When was Cassidy's procedure introduced? That was 1959. 1959. Is it a screening for biliary atresia? Stool card. You have seen the stool card. Yes, this is a stool card. So all babies should be given stool card. And if the mother feels that her baby's stool is like the first three, the baby should be brought back to the pediatrician. With this, lots of patients with biliary atresia have been diagnosed in many countries. Latest drug being tried in biliary atresia is high-dose IVIG. What's the diagnosis here? What's the finding? Near the cholestasis, you can see there is what is this? What is this?
Ullmann disease.
Bilateral adrenal calcification.
Who said it?
Krishna Priya.
That's right, absolutely right. That is Wallmann's disease. Bilateral adrenal calcification is called Wallmann's disease. Very good. Wallmann's disease. Minimal or no pruritus. Bilateral sympathetic disorders. So in this condition, the treatment is not with orthodeoxycholic acid, but with cholic acid. What's the relevance of this burden and cholestasis?
CMV urine examination.
You can see that.
The
urinary finding, all eye inclusion bodies of CMV. Shreyat, so with this time?
Sir, if you want to continue, we can continue, sir. Otherwise, we can stop, sir.
What is liver biopsy finding? This is the liver biopsy finding by child with cholestatic disease. It's diagnosis of which condition? Look at the description. PS positive, dashed magenta colored globular inclusions. The classic finding in which condition?
Alpha 1 antitrypsin.
Alpha 1 antitrypsin deficiency. We'll skip this. Billy scrotum for the diagnosis.
Sir, it is choledochal cyst.
No, it is spontaneous
perforation bile duct.
Congenital we already seen. Liver biopsy. A baby with cholestasis has very low serum cholesterol. What's the diagnosis? Very low serum cholesterol. Anybody? Very low serum cholesterol and cholestasis. Almost diagnostic of SLO, Smith-Lemli-Opitz syndrome. What's the dietary treatment for SLO? Egg yolk therapy. Egg yolk therapy. Okay? So these children should be given egg yolk. Near to cholestasis with polydactyly. Against Smith-Lemli-Opitz syndrome. Polydactyly. This is
gallbladder.
Cause of rickets, we already discussed that. Okay? We have discussed this. Cataract, congenital rubella. Again, that's a reversion question.
Characterizing.
What the gold standard for confirming the diagnosis of biliary atresia?
Liver biopsy.
No, it's a perioperative colonography. Cause of seizures we have discussed. Why we are using medium chain triglyceride, coconut. What is the advantage of a coconut? This is a very important slide for you because medium chain triglycerides are more water soluble. They do not require bile acid for their absorption. They can be absorbed directly into the portal circulation. They do not require. They can reach the mitochondria without the help of carnitine. So this is a very important slide for you. They can reach the mitochondria without the help of carnitine. Unlike long chain fatty acids, we can be transported to mitochondria only with the help of carnitine. Okay, I will skip some of the slides. So this is the latest drug, some of the recently described drugs for cholestasis. Please take it down. Cortisolum hydrochloride. This is the latest. Maralixibat is the latest drug for Alagir syndrome. Cortisolum hydrochloride and maralixibat, latest drugs. In which cholestatic disease is liver transplantation contraindicated? Zellweger syndrome. Remember that liver transplantation is contraindicated Zellweger syndrome in HLH, which are multi-system diseases. HLH and Zellweger syndrome, there's no use in doing a liver transplantation. Another condition is Smith-Lemli-Opitz syndrome. What the radiological finding here?
Dextrocardia, situs inversus polysplenia.
That's it. Polysplenia, you can see the ultrasound scan, you can see the polysplenia. Okay? Polysplenia. And the mebrophilia, what is this?
Hidrad's cancer. Mebrophin scan. Yes, sir. Even after 24 hours.
That's right. This is the laparoscopic finding of the same, but you can see that the liver is already cirrhotic, and this is the Kasai's procedure has been done, but this was the end result of that child. Okay. Now, last time, some of the last. Neonatal cholestasis, what are the causes of delayed referral? Number one is misdiagnosis of physiology jaundice. Improper follow-up of neonatal jaundice. If a baby continues to be jaundice even after 2 weeks, you should find out a cause for the jaundice, and the bilirubin has to be fractionated. You ignore the mother's complaint that the urine is high colored. And there is some amount of physiological diuresis which may tend to produce dilute urine. And people are so fond of helio. What is heliotherapy? Exposing the baby to sunlight. Is it practice in Thrissur? Maybe it is practice. Baby will be exposed to sunlight. And Lee50, this is a Lee52, very popular drug. In the country, they used to give Lee52. Supposed to be panacea. So all babies, even with biliary, they are given Lee52. So whenever you got a conjugate hyperplasia, refer the baby immediately. So a baby with cholestatic liver, if you don't think about it, if you don't think, you won't look for it. If you don't look for it, you won't find it. If you don't find it, you can't treat it. And if you can't treat it, you can't save the baby. This is the dictum for cholestatic liver disease. So till recently, pediatricians are receiving what is called a rod roller pace. What is rod? Rod roller, it goes so slowly. So they are giving some drugs like Lee50 and saying, don't worry, your baby will become all right. Lee52 heliotherapy. By that time, it will be quite late. Baby will be critically ill. But nowadays, due to the efforts of pediatricians, NNF, and of course pediatric gastroenterologists, we are referring, pediatricians are now referring these babies promptly. So this is called the fire brigade phase of investigation. Okay, this is the, you see the fire brigade, fire engine, a fire brigade phase investigation is definitely better than the road roller phase investigation. So take a message: conjugated jaundice is always abnormal. Roll out biliary test in non-neonates with conjugated jaundice. Identify treatable cause of cholestasis, and as already said, fire brigade phase is always better than the road roller phase. And thank you so much for listening to me. And
thank you so much, sir. Thank you so much, sir.
I would like to really congratulate Renu for the excellent presentation. She has passed with high colors. And I would like to congratulate all our teachers.
Sir. Thank you, sir.
All our teachers, including especially my own student, Shiji, Srinivas, Abharna Gulbadi. Oh, Srinivas are still there.
I learned a lot. It's Marathon. Yeah, every time I learn so many new things from you.
Thank you. Thank you. I'm sorry it took a lot of time.
No, sir. It was a wonderful, informative session. I think there is no questions in the chat box also.
He is super specialty training. It's, even DM they can pass, they can answer this much.
Thank you so much, sir. Thank you so much.
Okay, thank you.
So,
I have to congratulate you. You really did very well.
Thank you, sir. Thank you, sir. Thank
you,
sir.
She presented very well. Also. I'm really impressed with the presentation.
Thank you, sir. Thank you. Thank you so much, sir, for that very informative session. Thank you so much, sir.
Thank you.
My friend Prashant is also joined. Any comments, Prashant? Dr. Prashant?
Prashant is still there.
Prashant, unmute you.
I was actually reminded of SARS OSCE classes at least a decade ago when we were postgraduates in Trivandrum.
Actually,
Thank you,
Riyaz
Prashant.
was my examiner too. I was also feeling that way also.
I still remember Srijit as my examinee. Yeah, your face is very familiar. Yeah.
Okay, sir. Thank you, sir. So it was a long session, but it was a comprehensive and extensive coverage of neonatal cholestasis, right from the history next to the examination and finally the latest points also. Thank you, sir, for your efforts, sir, and thank you for your time, sir. So I thank all these senior faculties, Srinivasan, sir, Parvati madam, AK sir, and Reddy madam, and all the faculty of Amala Medical College, the Ramraj sir, Kalyani madam, Aparna madam, etc., for joining us today. And I also congratulate Renu for presenting this case wonderfully well. And I also thank all the postgraduates who have joined us today. And we will continue with our program next month. And also, before concluding it, I remind all the postgraduates to buy one ophthalmoscope today itself, as reminded by Riyaz sir, and join us with the ophthalmoscope in the next session. Thank you, all of you, and thank you.
Can I say one point?
Thank you, sir.
I once in Mahatma Gandhi Medical College, I asked all of them to keep their cell phones and the price tag, and then asked them to keep the stethoscopes. Stethoscopes are all Indian made and with a lot of leaky and other things. And as he mentioned, 50,000 phones, but stethoscope, they don't want to buy something, leave alone ophthalmoscope and otoscope. Even PGs don't bring it. It's a very good message. Thank you so much.
Thank you, sir.